Good morning, Guru.
Good morning, Guru Prasad.
Good morning, Johnny sir.
Urmala join cheyyannalle. Urmala first session ആയിരിക്കും.
അതെ ഫസ്റ്റും സെക്കൻഡ് സെഷനും ഉണ്ടെന്നാ പറഞ്ഞേ.
ഫസ്റ്റ് 2 ടോക്സ്. ഇനോഗ്രേഷൻ കഴിഞ്ഞിട്ട്
ഇനോഗ്രേഷൻ സ്റ്റാർട്ട് ചെയ്യാൻ പോകുന്നല്ലേ ഉള്ളൂ അല്ലേ?
സ്റ്റാർട്ട് ചെയ്യാൻ പോകും.
Good morning, Guru sir. Good morning, Jitin.
Goba, good morning. Goba mute ആണ്.
Good morning. കുറെ നാളായി കണ്ടിട്ട്.
ഫിസിക്കൽ മീറ്റിംഗ് എപ്പോഴാണോ?
രഞ്ജിത്ത് നടക്കാന്നാണോ?
സ്റ്റെപ്സ് എത്തിക്കണ്ടേ. ഗുഡ് മോർണിംഗ് ഗോപൻ.
അതിലെന്തെങ്കിലും ഒരു വെർച്വൽ ബാക്ക്ഗ്രൗണ്ട് വെച്ചിട്ട് സ്റ്റെപ്സ് എത്തിക്കാൻ പറ്റുമോ നോക്കാം.
വെർച്വൽ ബാക്ക്ഗ്രൗണ്ട് വെച്ചത്
ബാക്ക്ഗ്രൗണ്ട് മൂവ് ചെയ്യുമല്ലേ?
ജോണി സാർ സ്റ്റാർട്ട് ചെയ്തിട്ടുണ്ട്, യൂട്യൂബ് ഇട്ടുണ്ട്.
ഓക്കെ.
Good morning, Peter sir.
Hi, good morning. Good morning, everybody. Very good morning.
Good morning, Guru sir.
Morning, Dr. Johnny, Jitin, Guru Prasad sir, Gopa.
How are you, sir?
Very good. I am good. Perfect. Thank you. Nice Sunday morning. Everybody back to work, huh? सबको काम में लगा दिया.
ബാക്ക്ഗ്രൗണ്ട് ഒന്നും ഒഴിവാക്കി തന്നു. വീഡിയോ
Khalil sir join ചെയ്തിട്ടുണ്ട്.
Good morning.
Good morning, sir.
Good morning, sir.
Good morning, sir. Good morning.
Good morning.
Good morning,
So,
Good morning. Good morning.
Good morning, sir.
Then we will start.
Sir, start it.
Okay, good morning to all of you on a Sunday morning. I am Dr. Jalaluddin, chairperson of organizing chairperson of PHOCON. On behalf of organizing committee PHOCON 2021, I extend my hearty welcome to our national president, Dr. Piyush Gupta. He consented to inaugurate this conference. I also extend my thanks to our state president, Dr. T.P. Jayaraman. He will he will give the presidential address, and he also consented to release our e-souvenir of this conference. We are in a midway pandemic with vaccination also in the midway, and children are suffering, and they are bound to, they are back-driven in all fields, inclusive of psychosocial, educational, and even the treatment-wise also in hematological malignancies. So our themes is, this year's theme is care for all and cure for more. Cure for more and care for all. I think this will be fitted to the situation of our children in this era. So our conference should reach out to such children because they are worstly hit, especially that the management side of hemato-oncological malignancies. So our theme is apt in this era. So once again, I welcome all of the faculties, including our international faculty. He is from nearby place of Thalassery and graduated from Calicut Medical College. And also all the chairperson who give the consent to be the chairperson of this conference. Once again, I welcome all of the delegates and dignitaries who have logged into this conference. Thank you all. And I welcome our State President, Dr. T.P. Jayaraman, sir, to give the presidential address and afterwards the release of e-souvenir. Welcome, sir.
Good morning, everybody. Hope I'm audible.
Yes.
Respected President of Indian Academy of Pediatrics, Dr. Piyush Gupta, Organizing Chairperson, Dr. Jalaluddin, President IAP Thalassery, Dr. Sakaria, Dr. Secretary, Dr. Gopakumar, Secretary of IAP Kerala, Dr. Johnny Vincent, Dr. Jitin Tiki, the Organizing Secretary and Convener of the Pediatric Hemato-Oncology Subspecialty Chapter, Dr. Guru Prasad, Dr. Nandakumar, CIAP EB member, Dr. Satishan, Director of Malabar Cancer Center, Tellicherry, all the other dignitaries on the platform. It gives me immense pleasure to be associated with the first subspecialty chapter conference of Indian Academy of Pediatrics Kerala for the year 2021. And I'm so happy that we have our national president and the great academician, Dr. Piyush Gupta, to inaugurate this session and to deliver the keynote address. Pediatric hematology oncology as a subspecialty chapter is one of the most vibrant subspecialty chapter of Indian Academy of Pediatrics from the days it started. Actually, the entire subspecialty chapter started when I was doing it was the time when I was doing my postgraduate days, and those days the national award used to be backed every year by this pediatric hemato-oncology chapter. I'm telling about the time in the early 80s and 90s. Initial other years, they were winning the best chapter award, and that had been one of the most vibrant branches. And as Dr. Jalaluddin told, the COVID-19 has hit all the areas of life, and it has hit so hard the patients of this pediatric cancers as well as the chronic illnesses on blood disorders like thalassemia and hemophilia and all those patients. And it is very apt that you have got one of the wonderful, you have selected a theme as cure for care and cure for all and care for all. And I'm so happy that you got selected the faculties and topics so meticulously so that it will be one of the wonderful conferences in the academic calendar of IAP Kerala. And I'm so happy. No conference is complete without a souvenir to remember. And I'm so happy that in the short period, Dr. Jitin and his team has brought out a e-souvenir in association with this conference. And I'm very happy to release the souvenir. And I request Dr. Jitin to do the proceedings. Yes, I declare that this souvenir in connection with this conference is released. Thank you so much for giving me this opportunity to release this souvenir. And now I invite our national president, Dr. Piyush Gupta, to inaugurate the conference as well as to deliver the keynote address. Thank you all for this opportunity.
Thank you, dear Dr. Jayaraman, President IAP Kerala, organizing chairperson Dr. Jalaluddin, and Secretary IAP Dr. Johnny Sebastian, Dr. Guru Prasad, President IAP Hemato-Oncology Chapter, Dr. Zakaria, President of IAP Thalassery, Dr. Gopa Kumar, Secretary IAP Thalassery, Dr. Jitin, Secretary PHOCON Kerala, and Dr. M.K. Santosh, and all executive board members from Kerala. And I hope that the vice president of the zone may be joining soon. So it is a great day, and I'm really happy that this is the 12th annual conference of 12th annual conference of is being held now today, and with the theme is the cure for more and care for all, and that is a very appropriate theme chosen by the hemato-oncology chapter. And as you know that the hemato-oncology chapter is doing a great work, and the state chapter Kerala is actually active in all the chapters. So it is not only hemato-oncology, but hemato-oncology, as Dr. Jayaraman rightly said, that this was the main chapter which was active at that particular time also, and one of the oldest chapters. We have on the national front, you know that IAP with hemato-oncology chapter has started a smart clinic program under which CPC, that is a cancer prevention and cure, catch the cancer young in the pediatrician's clinic. That program has taken up, and it is aimed at catching almost or directing at almost 1 million children. The next step that we are going to do on the request of the hematology, pediatric hemato-oncology chapter also, is that already there is a DM program running in pediatric oncology, but there is no DM program running in pediatric hemato-oncology. So it is the chapter feels that we need to have a DM program in pediatric hemato-oncology as well. And we at Central IAP are fully with the chapter, and we will ensure that we make all our efforts and advocacy in this regard so as to get this into the curriculum and into the system as well. At the same time, also get a due recognition with the National Board and National Medical Council. So thank you very much once again for giving me the opportunity to be here. And I formally inaugurate this conference open, and I wish all the best for the deliberations and have a very happy learning throughout the conference. Thank you. Thank you very much. Good day.
Thank you, sir. Next, I welcome Dr. Johnny Sebastian to give felicitations.
அந்த மாதிரி பாய்கிறோத்தன்மை கண்கள் வெளியில உள்ள தட்பவெப்பத்துக்கு
Respected President and my leader, Jayaraman sir, the great academician, Piyush Gupta sir, President CIAP, esteemed speakers and chairpersons of the day, dignitaries on and off this platform, and my dear friends. At the outset, I would like to congratulate IAP Thalassery as they have organized the annual conference of subspecialty chapter of hemato oncology, IAP Kerala. As we all know, pediatric hemato oncology is a very rapidly growing subspecialty of pediatrics, and pediatric cancer awareness is one of the most important action plans of IAP Kerala this year. I congratulate the organizers for the meticulous selection of topics and faculty for this conference, as well as release the e-souvenir in such a short time. I wish this CME all success. Thank you. Jai Hind, Jai IAP.
Thank you, sir. Next, I welcome PHO chapter chairperson Dr. Guru Prasad to give the felicitations.
Thank you, Jitin. Respected Gupta sir, President IAP Kerala Jayaraman sir, organizing person Jalaluddin sir, Johnny sir, of course, and Dr. Jitin and Dr. Jitin. So every year we have been conducting IAP Kerala PHOCON, but this year I'm more proud because last month we have with Jitin's much effort we could start the cancer registry program into action, and for that probably the role of pediatrician all over Kerala is very important, so that it runs in a proper way. So I request the help of all pediatricians to contribute to the functioning of the registry program. In addition to that, I'm thankful for this program also, today's program, and I wish all success. And thank you, everyone.
Thank you, Guru. Next, I invite Dr. Zakaria, Thalassery branch president, to give the felicitations.
Respected IAP National President Dr. Piyush Gupta, State President Dr. T.P. Jayaraman, Secretary Dr. Johnny Sebastian, State President, State Past President Dr. M.K. Santosh, Organizing Committee Chairman Dr. Jalaluddin, Secretary Dr. Jatin, Chairperson PHO Chapter Kerala Dr. Guru Prasad, MCC Director Dr. Sadish B, other dignitaries, faculties, delegates, Dr. Gobu Umar, senior doctors, my dear friends, good morning. It's a great moment for IAP Thalassery to host this prestigious event, Kerala PHOCON 2021. I think this is the first state-level conference of IAP Kerala this year in the midst of COVID pandemic. This year, IAP Kerala also has one more accomplishment, that is, we could achieve our dream of making the pediatric cancer registry a reality, so that pediatric cancer become a notified disease. And I am sure that it will change a lot in the field of cancer management. I congratulate the Kerala PHOCON Organizing Committee led by Dr. Jalaluddin, Dr. Jitin, Gobu Umar for organizing this conference in a wonderful manner, especially in the selection of topics and speakers. I thank the state IAP leaders for the tremendous support and guidance to organize this conference in an efficient way. I welcome all of you who are present here in this Zoom platform, and I hope you will enjoy the upcoming academic feast. Thank you.
Thank you, Sakari sir. I think our Malabar Cancer Center director is, I think, held up due to some reasons and is not able to join the program. So we'll finish the program with a vote of thanks. So good morning all, respected seniors, colleagues and friends. So first of all, let me thank Dr. Piyush Gupta, the Central IAP President, for being here in this weekend and inaugurating the program and giving his keynote address. And I also thank Dr. T.P. Jayaraman sir, our state IAP president, who had been support and giving full support for all our projects for the PHO chapter as well as for this conference. Next, I thank Dr. Joni sir for being here and giving his felicitations, and he's been supporting in all the pediatric cancer related programs this year. I think I have to thank Dr. Sadishan sir, our director for the Malabar Cancer Center, who has been like in the forefront in improving the cancer care in Kerala, and is been supporting the pediatric team also in developing all this cancer care registry and improving the cancer access to care for children with cancer. I thank the Thalassery office bearers, Dr. Sakari and Dr. Gopakumar, being the giving full support for organizing and conducting this conference. It was a purely team effort, and within a short span, we were able to do that. It was a pure team effort, and thank you for all your support. And I also thank the faculties all agreed for being part of this conference in a short notice. Thank you all. And they also gave the materials for the ESO souvenir also in a short time. And I also thank all the delegates who have joined today. Wish you all an academic feast. Thank you all. I think we can start the sessions. So now, inaugural position, can we wind up?
Yes, Siri.
Okay, then I think next, I think we can start the academic sessions. Now I invite Dr. Urmala KV, Associate Professor, Department of Pediatrics, Government Medical College, Kannur, who is doing her PhD in hematology and was a past president of Hemophilia Society, Kannur. She had training in pediatric oncology from RCC Trivandrum also. So she will be chairing the first session, which has two talks. So I invite her to introduce the speakers as well as the topic. Urmala madam.
Audible alla madam.
Muted ആണ് madam. Muted ആണ്. Okay.
Is it audible?
Yes.
Thank you, Dr. Jitin. And at the outset, I would like to thank the organizers for giving me the chance to chair the session. And hemophilia is always a challenging subject, both for the doctors and for the patients, of course. And since the advent of factor replacement therapy, the quality of life of hemophilia patients have gone very far ahead. Their quality of definitely improved, but still there is a dilemma in choosing which factor and when to start the prophylactic treatment and what factor to choose and what is the dose. Like, there are so many questions in front of the treating doctors. And today we have an expert in the field of hemato-oncology, Dr. Khalil Ashraf. And I'm glad that he's an alumnus of Calicut Medical College, and he's now recognized as an expert in hemato-oncology and one of the America's top oncologists. And he had done his bone marrow transplant fellowship at University of Alabama, Birmingham. And as he has rightly described, he's across the multiple dates and multiple time zones. I hope this talk will be telling us a lot of facts and the recent trends across multiple time zones. Over to you, Dr. Khalil Ashraf.
Thank you for the kind introduction. And again, I appreciate this opportunity and good morning to you all. So I just, let me just start my timer here. Just want to make sure I don't exceed my 20 minutes. I know there are so many other important topics I saw in the agenda, so I will make sure that we don't exceed the time limit. So we're going to talk about some of the new advances in hemophilia. I'm not going to talk about some of the basics, and all you are all probably familiar with all the basic stuff. So I'm going to skip some of those stuff. We are going to talk. What are some of the newer things? I do not have any financial disclosures. I don't speak about any of the companies that make any of the products. So I just wanted to throw that up there. Don't have any financial disclosures. So in terms of overview, again, things familiar to you all. It's not an uncommon disease. It's 1 in every 5,000 males do develop hemophilia. Do remember that 30% of the patients may not have a family history and is from random mutation. And females can rarely be affected. And in fact, they used to be called as asymptomatic or symptomatic carriers in the past, but nowadays, depending on the factor level, we actually call them mild or moderate hemophilia, even if they are, even if it's a girl or a female. The age of onset is depending on how severe is the disease. If it's severe, it can be even at birth or within 1 month sometimes, moderate within 1 year, and mild cases usually present within the first 3 years of life. This is a molecular basis of hemophilia. Again, I'm sure you must be familiar with all this. So the severe mutations, the common things we do find is basically the intron 22 inversion, as well as intron 1 inversion appears to be more common in patients who have severe hemophilia. Again, these type of mutation and the extent of deletions and the specific mutation at what splice joint, all this will determine how severe is the case. Now, some of the advances in hemophilia treatment, we do know prophylaxis do help these patients. It decreases long-term morbidity and mortality, especially in severe cases. So we have approved treatment for prophylaxis as well as treatment. There are the short or the standard half-life factors, and then we have the extended half-life factors. And I might be focusing a little bit more on the known factor replacement. So the so-called the bispecific monoclonal antibodies and some of the emerging therapies. I do not think we have time to go through all of them, but we'll briefly discuss some of them today. So these are the challenges we all face as clinicians in treating this disease. It could be, primarily because of the half-life, the dose-related problem, high infusion frequency, especially in the prophylaxis setting, decreased adherence, especially for adolescents, and the need for an IV access, which is a big deal, and maintaining the trough levels. These are the common dose-related issues, and of course, disease-related problems. We don't want to we want to make sure these children and young adults and adults have a near normal life and activities. So we want to prevent breakthrough bleeds, especially long-term hemophilic arthropathy and other spontaneous bleeds. Now, in terms of extended factors, the ones we have, and I'm sure it's probably available in India too. So these are the extended half-life factors we have. And you can see the half-life is definitely better than the standard half-life. Some of them almost as much as 22 hours. So this is definitely a move in the right direction. The main advantages of this is that you can encourage better compliance. There is decreased frequency of IV injections. This is important, especially in adolescents. And it increases the trough levels. And with extended prophylaxis, there is less subclinical bleeds. There is less problem with the joints, and does increase the patient's quality of life. Now, the problems with the extended half-life, it doesn't prevent inhibitors. And in patients who do have inhibitors, it doesn't help, just giving them extended prophylaxis. And untreated population, there is a risk of inhibitor development, especially in the first 50 days of exposure. And we also know that endogenous factor, von Willebrand factor, is another factor that interfere with the half-life of the factors. Now, in terms of half-life, even though I showed the slide showing different half-lives, we all know the PK of these products vary from patient to patient. And younger people generally tend to have a shorter half-life for most of these factors. Now, coming into the more exciting known factor treatments for hemophilia, this is where there is a lot more interest nowadays because of various factors. Now, the one that we have approval for, which I think I'll spend a little bit more time, is bispecific monoclonal antibody. So basically what it does is it's an antibody that does the work of factor VIII. So factor VIII basically connects or activates, as a bridge between factor 10 and factor 9. So this bispecific antibody work just like factor VIII. So it is not factor VIII, it has no homology to factor VIII. The molecular structure is different. So if you have an anti-factor VIII antibody, this wouldn't recognize this particular antibody. This was developed by a Japanese researcher over a period of 10 years. He tried out about 40,000 molecules and finally found this particular molecule that can actually work as factor VIII. So it is not factor VIII, but it's a bispecific monoclonal antibody. The name of the drug is emicizumab or Hemlibra. And I just looked it up while you all were talking, whether it's available in India, and it does look like it is available, and some of you may have already used it. So what's the big deal about this is two big deals. One, it is subcutaneous and it doesn't require an IV access. And in terms of half-life, it's a big quantum jump. The half-life is about 4 weeks. So that's a big difference than a regular factor VIII. And also, like I mentioned, the anti-factor VIII antibodies doesn't interfere with the action of this drug. So these trials were called the Haven trials. Again, I'm sure some of you might be familiar with this. There were 3 Haven trials, Haven 1, 2, 3, 4. So the total number of patients enrolled in the trials were about 401. But post trial, we do now use it outside of clinical trial also. So there are thousands of patients who have received it after the trials. And if you look at the age group, which I think is important for this particular group, your pediatricians, and of course, as adult doctors, I do have the greatest respect for you all because, taking care of children is very special, very difficult. But anyway, so the trials did include patients as young as 1 year. And after trial in the clinical experience, this has been used in patients as young as 1 or 2 days. So this drug has been used in younger people. FDA approval doesn't specify the age. And this is other the different subgroups within the trials. There were about 18.7% Asians within the population. So this is the mean annual bleeding rate. ABR is the annual bleeding rate, and you can see that there was a sustained efficacy and low annual bleeding rate across the group. I might be going through a little fast. I will be happy to share this slide if anyone is interested, so that you all can go through this just to make sure that I don't exceed the time limit. So in terms of surgical experience, there has been use of this drug as prophylaxis prior to surgery. And we do know that it can work just like factor VIII. One important aspect to remember with emicizumab is that its activity, when you combine it with the PCC or prothrombin complex concentrate, is synergistic. It actually exacerbates and it can cause thrombosis. So now there is a black box warning. Now we do not use APCCs along with this drug. Of course, there are rare occasions where you might, but in generally, it is something that you want to avoid. So breakthrough bleeding usually is treated with factor 7 or Nova 7. The rare cases of thrombotic microangiopathy also has been reported when it is used with the APCC. Again, thrombosis with factor 7 is rare. So that's important to remember. If you have a patient on emicizumab, do have a breakthrough bleeding, you do not want to use APCCs. Now, as I did just mention, the problem is prothrombin complex concentrate do contain factor 9 and factor 10. So when you give them the emicizumab, it is actually going to exacerbate, increase the thrombin generation. So this is physiologically synergistic. So that's why you have to be very cautious using this with APCC. Whereas using with factor 7 or Nova 7 is not additive. So thrombin generation remains below normal in that subgroup of patients. So this could be due to the short half-life of factor 7 also. Now, this is not a surprise if you ask a child who is getting factor 8 or standard or even extended half-life, getting IV injection every day or twice a day sometimes as a prophylaxis. And you ask them when they get a medicine that is sub-Q and once a month, they generally prefer this. You can see the extent of people who prefer the sub-Q version of this is definitely, almost all the patients prefer this compared to the prior therapy. All right, so next, what else we can do other than factors in treating factor VIII deficiency? So this is the standard coagulation pathway we all remember from med school. Not a whole lot has changed here. Just remember that these are not independent as we used to think. Both intrinsic and extrinsic pathway works very much together. You can't have extrinsic pathway alone. That's why when you have factor VIII deficiency, the intrinsic factor cannot replace the loss of factor VIII. But anyway, so this is some of the other factors, TFPI and antithrombin, where we could potentially act and act as drug targets. So one of the drugs that is very close to clinical approval is fitusiran, which is a small molecular siRNA. And there are several drugs in this group where we can monitor or interfere. This is a interfering RNA that actually decrease the production of antithrombin 3 within the liver. So this is again subcutaneous, which is great. And also it has a fairly long half-life. So the mechanism is you give the interfering RNA, which interferes with the antithrombin production within the liver. So you're creating kind of a antithrombin deficiency, so to speak. So this is the trial design, the fitusiran trial design, and this is given subcutaneously monthly. Again, much more patient-friendly. So what you find is that you can see, depending on the dose, you can see a decrease in the antithrombin levels. It's dose-dependent fashion. And it did, you can see the number of bleeds are decreased when you give them antithrombin 3, as expected, because when you decrease antithrombin, whatever thrombin is generated, stays longer. So even in patients who have hemophilia, they still do have low levels of thrombin, and when you decrease the antithrombin, whatever thrombin they have made is going to last a little bit longer. So this is a phase 1, phase 2 summary. It is dose-dependent knockdown of the antithrombin levels, and there is a concomitant increase in the thrombin generation, and this decreases the bleeds. Now, there was one thrombosis-related death. So this was a high-intensity, high-dose factor replacement therapy during the fitusiran. So this, again, just a guideline changed that while your patient is on this, you want to be absolutely cautious. You don't want to give them extra factor VIII because they're going to develop thrombosis. This is the current phase ATLAS trial that is looking at how this is going to be effective, and this is where we we will know how effective this is after we get the results. Safety, as we mentioned, one patient did have thrombosis-associated death, and this was a patient in the open-label extended trial, and this patient was getting factor VIII. There was also increase in ALT, and this was all patients who have hepatitis C. So there were some patients who have elevation of the liver enzymes, and in patients who have previous hepatitis C infection. TFPI is another target where you can treat hemophilia without using factor. So anti-TFPI, which is an antibody. So this is also in late stage clinical trial. Hopefully we should have this approval within the next a year or two. So it's concizumab is the name. Now, both the concizumab and emicizumab, as you remember, the naming of these drugs end with zumab. When you say zumab, it is more humanized. So even though there is a possibility of anti-drug antibodies against both concizumab and emicizumab, for drugs that are ending with zumab, anti-human antibodies are rare. So, but it can happen. So you can, if you have a patient who have either getting conci or MC and appears to be becoming resistant, one of the possibilities that they're developing anti-human antibodies. So this is a trial design for concizumab. So again, dose dependent. What you're trying to look is basically bleeding episodes and thrombosis, just like other, other factors we mentioned. So what we found in phase 2 results is more than 75% reduction in the annual bleeding rate, and especially in patients, even in patients with inhibitors, in patients with inhibitors, and in also severe hemophilia patients without inhibitors, it did decrease annual bleeding rate. So quickly recap, how do you incorporate some of these drugs that are coming in the pipeline that are longer half-life and can be given subcutaneously. This is some of the potential candidates: people who have poor venous access, people who are physically active. I see here people who, even with the hemophilia, tend to be quite, exceedingly active, sometimes a little too much. Then the people who have severe phenotype, severe bleeding phenotype, people who have severe hemophilia along with poor adherence. And of course, inhibitors. The first approval of emicizumab was in patients who have inhibitors because this drug doesn't have any homology with factor VIII, and decreased, those who prefer decreased dosing frequency, which is probably everybody. One thing I did want to highlight is the treatment of bleeding in these patients. You have to be absolutely cautious, and you should avoid APCC, as there's been reports of TMA and thrombosis. And this is one short guideline how to treat breakthrough bleeding in these patients. You do want to use factor 7, NOVO7, except in very rare cases. There are some rare cases where you may have to use APCC, or you have to use the old porcine factor VIII, which used to be the only treatment or the main treatment, along with the factor FIBA and other bypassing agents for inhibitors. Some of the blood testing to remember: the emicizumab does affect your APTT and Bethesda. Some of this test clotting time, but it doesn't affect some of the other tests like thrombin time. So again, individualize the treatment depending on the phenotype, the PK, if you have access to checking the PK values, comorbidities, joint health, IV access, and I think most importantly, here, fortunately, we don't have to worry too much about insurance pays for most of this. These drugs are so incredibly expensive. Hopefully it'll come, that's one of the biggest side effects of these drugs. So hopefully the price will come down. So it will be, these great drugs will be available for more patients. So in summaries, there are several new treatment options. You can individualize treatments depending on the severity of the disease and the patient compliance. And there are several known factor therapies that are in the pipeline. So, something to keep in mind. And that's my last slide. And, just a historic slide. We all know the story of the Rasputin and the Russian prince. But, this all started with Queen Victoria, and, she gave it to a ton of her, and they're all cousins, they all intermarry each other, so they all get a lot of consanguineous diseases. So, and in fact, this was hemophilia B, by the way. Queen Victoria was a carrier of hemophilia B, not A. And that's my talk. And if we have time, maybe one or two brief questions. Thank you all for the kind attention.
Urmila, madam.
Okay, we move on to the next topic.
I think, Khalil sir, can you wait until the end of this session? Next talk also, then we can ask for the discussion for some time.
Or we'll discuss this topic and finish it off. I think that's better.
Okay.
I think the discussion was almost very complete, precise, and to the point. And regarding this pipeline drugs like emicizumab, available in India, and I think in Vellore they are using that. So still for us, it is only we can hope for those drugs. That's all. And if it is coming, I think it's a real breakthrough, because it's of venous access, because we are very much bothered about this venous access, especially for small children. And is it open to discussions?
Yes, ma'am.
Any questions from the audience?
Urmila, can I give a comment?
Yeah.
Ashraf, nice seeing you after a long time. It was a nice talk. Dr. Ajit here.
Oh, hey, how are you? Thank you.
Fine. And one comment and then a question. One comment is that we are planning to give emicizumab next month onwards free of cost for children who are inhibitor positive and also having high titers with difficult venous access. So the government of Kerala has approved that, and we are just in the phase of listing out patients for emicizumab. And as you have said, it's a wonder drug which has to be used for prophylaxis because subcu, it is being subcu, and the quality of life is definitely improved. And so we are in the process of line listing the patients all over Kerala, and around 9 crore have been allocated for emicizumab for in Kerala. So maybe we'll see what will happen. Our data may be for emicizumab. And one question for you, Ashraf, and I want to know which factor rate you usually start during the first 50 days, like prophylaxis. Which type in the initial 50 exposures?
You might be surprised. Many of the time, our decisions have to be based on the insurance company. So, so it depends on, so most of the time we get our patients who are already on some factors, because we don't, we are adult doctors, and we actually here start seeing the patient only after age 18. Here, pediatrics is up to 18. So by the time we see them, most of those people who are already, on some prophylaxis, they have started on that, and we generally just continue that. So, I'm sure you guys probably have more expertise in the beginning stages than I do. As I mentioned, I do not see pediatric patients.
So basically, I think it would be better. I don't know whether I'm right or wrong. Whether to use the factors which are less purified or plasma derived, or in the initial phase, or recombinant.
Yeah, Yeah, plasma derived is, unfortunately not as much used here, but I think in terms of inhibitor, yeah, I think it is reasonable to use that.
Thank you.
Yeah.
And nice to see you.
Thank you.
Problem is we get mostly this recombinant factors as a part of this HFI. So here patients are not very compliant, especially the young pediatric population who are not registered in the hemophilia program. So they get to use whatever factor is available at present. So most of the times they get this recombinant factor which is available in the with WHI. So HFI. So that's a real problem, as sir truly pointed out. This can make the inhibitor levels high. So that's really a problem. I think it has to be taken up by the HFI, because different factors getting at different times, and the Karanya pharmacy we are getting a totally different plasma derived factor. So maybe the patients are using one time they are using recombinant factor, the other time they are using the plasma derived factor. So on it is going. So and the inhibitor level checking is also very infrequent.
Yeah, very unfortunate. And once they develop inhibitors, at least here, it's so expensive, and it became out of control. Anyway, thank you so much for what you all do. Like I said, I have great respect for pediatricians. I mean, it's hard job.
One comment, his wife is a great pediatrician, pediatric endocrinologist. Dr. Ambika.
That may be why he's so favorite pediatricians.
No, I mean, I always thought pediatrics was one of my, I always found it is so difficult. I couldn't make out most of the things. So, I mean, yeah. That's why I think in Kerala, all the smart people went for pediatrics during our days. Anyway, thank you so much, and good morning, and I appreciate all of you doing this. Bye.
Thank you, Dr. Kelly, and thank you, Ajit sir. Jitin, can we move on to the next session?
Yes.
Yeah. Can I share? Can you just enable me?
I have a job of introducing you, sir.
Okay.
So when we get a child with, when we do CBC for any infection or any child coming to the OPD, when we do a CBC and when we see the total count as 2,000 or 3,000, we start to get worrying. And when we go down the hemogram, if the HB is also less, our heartbeat goes even high. And when the platelet count is also less, we are really in a fix. So such situations, I think it's a really challenging situation for a pediatrician. So I think we are now into a session of diagnosing pancytopenias, all the problems and difficulties faced by a doctor while managing pancytopenias. And here we have an eminent doctor, Ajit Kumar sir, and telling about him, is a very genuine person, is a great mentor and my own teacher. And he is now the HOD and professor, Calicut Medical College, our own medical college. And he is now into hemato-oncology. He is heading a division of hemato-oncology also. And over to you, Ajit Kumar sir.
Okay, thank you. Can you just enable me to share this?
I think you can start. Share.
Okay. Hello. Urmila, is it?
Sir. Yeah, sir.
Okay.
Yeah. Sir.
Am I audible? Yeah. Am I audible?
Yes, sir.
Yeah. Yes, sir.
Okay. So, respected teachers, senior pediatricians, dear friends, and it's an honor for me, and I thank IAP Thalassery branch, its president, secretary, especially Dr. Jitin, for inviting me. So today topic is on pancytopenia. As Urmila said, it's not a very rare condition, but we often see it. So in this talk, I would be looking at the definition, clinical features, some cases, and an approach to pancytopenia in children. Okay. Let's start with the case. It's a 7-year-old child who presented with a fever and gum bleeding of 1 week duration, first child of a non-consanguineous parent, and had pallor. On examination. Child was febrile and had a brownish macules over the back. There was pigmentation, and there was abnormality in the digits, and all the lab, all the cell lines were decreased. That is hemoglobin, total count, everything was decreased. So it's a typical, and platelet was also decreased. So it's a typical case of suspected pancytopenia. So before going to detail of this case, how will you evaluate before you evaluate this case, we will go to some of the definitions. So pancytopenia refers to decrease in all peripheral blood, and bicytopenia is reduction in any of the 2 cell lines. We call it bicytopenia. If you have reduced granulocytes, called granulocytopenia. If you have neutropenia, is if the ANC is less than 1,500, and lymphopenia is defined as if you have absolute lymphocyte count less than 3,000 in less than 1 year and less than 1,000 in older child. So pancytopenia, all the cell lines are reduced. The hemoglobin is reduced. There will be anemia, less hemoglobin less than 10. There will be total count will be reduced. There will be leukopenia as well as thrombocytopenia. But very important to find out whether we are dealing with a severe pancytopenia, where the hemoglobin will be less than 7, ANC will be less than 500, platelet will be less than 20,000, and reticulocyte count will be very low, less than 1. So these are the definition of, these are some of the definition of severe pancytopenia. So how does this happen? How does pancytopenia happen? So there is a depletion of stem cells, and as well as the progenitor cells, either due to a damage in the environment near the stem cell, or some clonal disorders affecting the stem cell, or maybe replacement of the stem cell by tumor or fibrosis. Sometimes from a pluripotent stem cell to a committed stem cell, there might be maturation defects, or the formed cells might be destroyed either immune or by non-immune. Classically, they are the causes of pancytopenia is classified as inherited or acquired, but better to classify under 2 headings, like whether they are having a hypocellular bone marrow or a cellular bone marrow, because all the children with pancytopenia needs bone marrow examination. So hypocellular bone marrow, you have the inherited bone marrow failure syndromes, and there's some of the acquired aplastic anemias and drugs and post-chemo and post-radiation, while the cellular marrow are usually systemic disorders, and we have the primary bone marrow disorders like myelodysplastic syndrome, myelofibrosis, leukemias, while in the systemic disorders we have the B12, the folate deficiency, hypersplenism, and all the infections, and some of the storage disorders and some of the infiltrations by solid tumors. And most of the studies from India have shown that megaloblastic anemia is one of the leading cause for pancytopenia. But when you consider the severe pancytopenia, the aplastic anemia tops the list. And when you talk about malignant versus non-malignant, the non-malignant causes of pancytopenia comes top in the list. So we should be aware that all cases of pancytopenia are not malignant, and there are non-malignant causes. The most common cause age group is 1 to 5 years. When you look at the bone marrow distribution, then there are more cases of megaloblastic erythropoiesis. So there are more treatable causes of pancytopenia in children. And in the Indian context, malnutrition is a very prominent problem as a cause for pancytopenia. So how do they present? So it depends upon the degree and duration as well as the underlying cause. Could be it could be due to anemia, which may present as shortness of breath, features of cardiac failure. There may be signs and symptoms of tachypnea, tachycardia, or they may be having neutropenia in the form of recurrent infections or mouth ulcers, which may be seen, or they may have bleeding manifestations in the skin or mucous membrane and underlying features of underlying systemic disorders. So these are the common symptoms which they had present, that most of the children with pancytopenia present with pallor, fever, and bruises. So any child with this combination, it is better to evaluate the child for pancytopenia by taking a good history. So a good history is very important as in any other case, and also a focused clinical examination, and also investigations which are mandatory, including CBC, smear, and bone marrow examination is usually mandatory in most of the cases. So if you're taking a bone marrow, it is better to do a bone marrow aspiration as well as take a biopsy. Before proceeding for a workup in a child with pancytopenia, it is very pertinent to find out whether we are dealing with an emergency conditions. So these are medical emergencies, like a febrile neutropenia, where you may have to treat emergently with antibiotics, or if the ANC count is less than 100, or if they have a symptomatic anemia, or if the thrombocytopenia is very severe, less than 10,000, or if you're dealing with a DIC or a suspected leukemia or HLH. So they need emergency treatment. You cannot follow up them like in an OPD basis. They may have to be admitted and treated. So take a detailed history on the duration of the disease, bone pain, and have what you call a good clinical focused history. Leading questions may be asked about jaundice, looking for hemoglobinuria, weight loss, joint pain, ask for seizures, abdominal discomfort, or exposure to infections or drugs. Most very common, it's not uncommon to find out that many of them have some drugs like NSAIDs or some other common antibiotics, which may sometimes be a cause for an pancytopenia. And never forget indigenous medications like Ayurvedic preparations or herbal preparations, which may sometimes produce pancytopenia. So, like heavy methyl. A focused clinical examination is very mandatory. So you have to look for short stature, as this child had, dysmorphic faces, ears, low-set ears, eye, oral cavity, skin. This child had reticular pigmentation, capillary spots. So these are some of the manifestations. This child is having a Fanconi's anemia. So from a detailed examination from head to foot is very essential. In dyskeratosis congenita, you may have nail atrophy, skin changes may be seen. Oral cavity, look for cheilitis, gingival stomatitis. And these are the dyskeratosis congenita. These are the diagnostic triad. So a detailed examination is very much needed. Sometimes you may pick up a child with leukemia or with gum hypertrophy, and you may diagnose a condition. And this is B12 deficiencies. So a focused examination is very much needed in a child with pancytopenia, looking at lymph node enlargement, looking at hepatosplenomegaly, respiratory system. You have to look for tachypnea, look for mediastinal mass, musculoskeletal system, very important. Look for CNS central nervous system. So this is a Fanconi, this is a dyskeratosis congenita we had. So after a thorough history and examination, mandatory to do a CBC, retin smear, retic count, and a bone marrow. And from the bone marrow, you can look at the cellularity. So you should have a liaison with a good pathologist who can, a smart pathologist who can look at all these things. And you may have to do a immunophenotyping and a cytogenetics from the bone marrow and other investigations for specific disorders. And so CBC is a very important tool to diagnose pancytopenia. Where we can look at all the form cell lines, WBCs, platelets of hemoglobin, and also look for, you can get a diagnosis by if you see a macrocytes with a increased RDW, and it could be a megaloblast. So you can get a diagnosis of leukemia and all. Even so, CBC basically an objective way of looking at the smear. And peripheral smear, you can make a diagnosis of a sickle cell or a megaloblast, macroollocytes, or in aplastic anemia. Usually they are normocytic, normochromic. You may also diagnose an ALL or an AML from the smear. And you can look at the distribution of the platelets. And if you have a normal platelet count, more or less rules out aplastic anemia. So bone marrow examination is always indicated in children with pancytopenia. And it is very important to do both aspirate as well as biopsy. and send them for immunophenotyping or cytogenetics whenever needed. So you have to do a bone marrow aspirate smear as well as a trypan biopsy. And you can classify them as a hypocellular or a normocellular. So these are the hypocellular causes: aplastic anemia, hypoplastic MDS, lymphomas, cytotoxic agents, which may, or you could be a cellular bone marrow, as I said. It could be a leukemia or a HLH or a PNH, or it could be some of the systemic disorders like B12 deficiency or collagen vascular disease, storage disorders. So all this may produce a cellular bone marrow. Just moving to a second case. This is a child who had, it's a 4-year-old child who was malnourished, had pallor, icterus, and had a hepatosplenomegaly, had anglostomatitis child. And this child had, so these are the differential diagnoses that we had. 4-year-old child with the weight is very low. And this child had pancytopenia. This hemoglobin was low, total count was reduced, platelet was also reduced. MCV, the important thing is that MCV is high. So even from the CBC, we can make a more or less what do you call a conclusion, not a conclusive diagnosis, but a suspicion that it could be a megaloblastic anemia. So from the smear, there is a hypersegmented neutrophils. And bone marrow, you see a megaloblast. See the megaloblast. And you do a B12 assay and you can confirm a diagnosis. Megaloblast. So all aplastic anemias are not or pancytopenia are not aplastic. So as seen in this case, it could be a megaloblastic anemia. So look out for the possibility of megaloblastic anemia in children with pancytopenia. This is a 6-year-old child who had petechiae, gum bleeding for 3 days duration and fever of 1 day. And there was a history of similar illness 4 to 6 weeks prior, and treated for 2 weeks. And on examination, child had cervical, axillary lymph node, pallor, spleen bleeds, and hepatomegaly, but no splenomegaly. So this could be any viral infection like a dengue and all these things. But the problem is, child had pancytopenia, or it could be an HLH also. And there was lymphocytosis. So if you have a high lymphocyte count, that's a pointer, a red herring marker. So we did a bone marrow, and the bone marrow aspirate turned out there was scattered blast, and bone marrow biopsy also with occasional blast. And immunophenotyping was done, which showed a leukemia. So basically, very important to look at the treatment history also, because sometimes the case the case might be modified by drug which has been given previously, like steroids. So you can get leukemias presenting as pancytopenia, like ALL or AML, they may present as pancytopenia. This is another child who had was a 2-year-old child with excessive crying and irritability, and child was also malnourished. Child had pancytopenia, and there was anisopoikilocytosis and lymphocytosis also. We thought it was leukemia, but basically it was a bone infiltration by neuroblastomas. So sometimes it could be a metastasis from other solid tumors also. This is another child who died recently. Any diagnosis from the chat box? This is a child with, see that extensive fair child. Child had a lymph node enlargement on the right side. She had
Chidia-Higashi.
Yeah. This child had a Chidia-Higashi syndrome, and the ANC is very low, and WBC was low, platelet count low. So what will you suspect in the Chidia-Higashi? All the cell lines are reduced. So it was a hemophagocytosis. So HLH-like picture. So in a Chidia-Higashi, if you have an HLH-like picture, this was a hemophagocytic. Child had bone marrow, child had a hemophagocytes, prominent hemophagocytes. So it was an accelerated case of Chidia-Higashi. So that may present as pancytopenia. So even so, some of the disorders like Niemann-Pick, storage disorders like Niemann-Pick, or which may infiltrate bone marrow, or Niemann-Pick, or all this, or a neuroblastoma, which I already said, they may present as aplastic anemias. So in addition to the CBC, peripheral smear, and bone marrow, and reticon, the other tests that we usually do, depending upon each cases, are immunophenotyping, to look at leukemia, cytogenetics. You have to look for bone marrow, look for, it's very important because one of the conditions which I usually do is an X-ray in children with bone marrow to rule out osteoporosis. So this is one condition which you can easily diagnose by X-ray. So B12, if you think that it's a B12, you do a B12 folate testing. And all the serologies like hepatitis B, HCV, EBV, flow cytometry, chromosomal breakage analysis for Fanconi syndrome, autoimmune panels for DCT and for collagen vascular disease types. So all these things are other ancillary investigations that you may have to do depending upon. So the child, the 7-year-old child with brownish macule pap, macules of the back, perioral hyperpigmentation. So this child, what do they have? This child had a severe pancytopenia, hemoglobin was low, total count was low, ANC was low, and also it was an inherited cause. And we did a bone marrow, and it was aplastic, and a chromosomal breakage analysis has to be done, and it turned out to be Fanconi syndrome. So, depending on the case, you may have to do different tests. So, coming to the final 1 or 2 slides, last slide. So basically, you do a bone marrow aspirate in all cases of the, in addition to CBC and peripheral smear, and you classify whether it's a hypocellular or a cellular bone marrow. In hypocellular marrow, you have the acquired aplastic anemias, constitutional aplastic PNH, and all these things. In cellular, we have the primary bone marrow disease like leukemias, lymphomas, or sometimes, or you may have to look for secondary systemic diseases like collagen vascular disease or B12 deficiencies, or some of the malarial, or sometimes very rarely Kala-Azar. And so this is the algorithm of pancytopenia. So some of the things that I would want to stress is that the pancytopenia is not it's a triad of finding resulting from number of diseases, and diagnosed course definitely requires bone marrow aspiration. So you have to send a child to, if you're suspecting pancytopenia, send a child to a facility where they can do bone marrow aspirate cytology, as well as immunophenotyping and cytogenetics. It's a very common cause, megaloblastic anemia, and look for symptoms like early recognition of this condition is very important. And fine, very important to look at the critical area like febrile neutropenia or ANC less than 100. If you have very low platelet count and all these things, so refer them early. So thank you very much.
Thank you, sir. Thank you, sir, for the very elaborate presentation. And pancytopenias are always a little bit confusing. And I have one doubt. You go as a panel or panel of investigation for all cases, or sometimes it could be just sepsis, especially in very young babies. Pancytopenia could be sepsis also. Or do you wait for treatment results with antibiotics and then go for invasive investigations like bone marrow and all, or straight away you go to the panel?
Some of the sepsis you may have HLH-like picture. So it's very important. We are seeing children with scrub typhus and all this, wrestling with pancytopenia, or we had children with even COVID having pancytopenia with HLH-like picture. So it's very important to you can identify the hemophagocytosis in children with this condition. So it's better to do a bone marrow examination in conditions where you can do it. But if you're definite, otherwise, because some of these children might need a steroid or a methylpred or something like that. So if you're dealing with some malignancy and all, it might be masked. So better to do a child who have pancytopenia, better to do a bone marrow examination, if possible.
And what about bicytopenias? Do you go for a marrow always?
Basically, what they say is that if the more than if your 2 cell lines are affected, you have to look at the conditions, and if bone marrow is indicated, it has to be done, because we have seen not all bicytopenias. Not all bicytopenias need bone marrow, but better to look for conditions, because we have burned our fingers by treating them. Later, it turned out to be malignancy.
Okay. So the take-home message is a bone marrow examination, and I have seen that many centers they treat with. I mean, not many centers where facilities are not available, maybe, but they tend to don't attach much of importance to bone marrow aspiration because it's quite an invasive procedure, and they treat with antibiotics, and sometimes as Sir said, we quite burn our fingers because the treatment of, I mean, most of the times it might turn out to be leukemia and all. And it is quite reassuring to see that most of the cases may not be any malignancy or some dreaded conditions. It could be even malnutrition presenting as pancytopenias. It was quite reassuring to hear that. And I think it is open to discussion.
Probably we should avoid steroids as part of any disease that you are managing.
Yeah. Steroids can alter the picture of malignancies, but we have no control on the treatment, especially referred from outside, because dengue fever can, in an epidemic situation, even dengue fever can present with pancytopenias. So in a fever, that's all, but there is no indication for steroids in such situations. But such cases, at least some of them do have at least some doses of steroids they get. So it's definitely a problem. Thank you, Ajit sir.
I should also thank Dr. Fauzio for providing me for some of the materials and images. Thank you.
And one more doubt: do you treat this vitamin B12 deficiencies with injections always, or you just give oral drugs?
We usually give injections initially. Initially, we give.
Thank you, sir.
Thank you. Thank you.
I think there are no questions in the chat box. Can we conclude the session now, or?
We can conclude.
Madam, can you give some closing statement?
Pardon?
Closing statement.
I think we have dealt with two important pediatric diseases, not only pediatric, but since we are pediatricians, we are more concerned about the pediatric issues. One is hemophilia and pancytopenias. I think the speakers did an excellent job in conveying us the latest trends and also the clinical pictures and the clinical scenarios. And thank you once again, Dr. Khalil Ashraf and Ajit Kumar sir. I think we can move on to the next session, probably. Jitin.
Okay, ma'am. Thank you, ma'am.
Thank you.
Thank you for sharing the session. Next, I invite Dr. M.K. Sandosh, our past IAP state president and backbone of our IAP Thalassery branch, director of Mission Hospital, consultant pediatrician. Welcome you, sir, for chairing the next session. Kindly introduce the speakers as well as the topic.
Good morning. Good morning to you. I think I am audible to all of you. Jitin?
Yes, sir. Yes.
Yeah. Next topic is leukemia and its varying presentation. The speaker is none other than Dr. Badira C. Parambil. This beautiful doctor studied in Kerala, specifically Calicut and Thrissur Government Medical Colleges. And she went to Tata for higher studies. And now she is working as an assistant professor in pediatric oncology in Tata Memorial. Her father is a close friend of mine, and her special interests are in Hodgkin's lymphoma, sarcomas, and in immunotherapy. Her hobbies, of course, travel, and as a typical Malayali, she enjoys food a lot. Today's regarding the topic, varying presentation of pediatric leukemia. You all know that leukemias are the commonest malignancy in pediatrics, and luckily it has got a very high cure rate. But to diagnose such condition early, you should have high index of suspicion. And they have a varying presentation. Early diagnosis can help preventing complications and also to increase cure rate. Over to you, ma'am.
Thank you so much, sir, for the kind introduction. Good morning to everybody. And I'm very happy to see my teacher also in here. And I think he can teach you more about all these things on his whiteboard behind him than me. It's very nice to see you, Dr. Purushothaman, sir. So without much ado, I will share my screen.
You're a co-host now. You can...
Okay, yeah, I'm trying to find my screen. Is it visible now?
No.
Did it? Can you see
No,
that?
not visible, not visible.
No.
Okay.
Mac no.
No, original. Just a minute. I don't know why Microsoft. Can you share?
MacBook no.
Yes, Mac.
Okay. Sharing privilege Mac activated on.
Just a minute. I will just hold on. Can you go on to the next one? I will just do the. I think there is some problem with my this thing. I log in from a different.
Okay. Guru is ready?
Then can you go on with the second session? I'll come back.
Oh, yeah, okay. Yes. Sandosh sir. Sandosh sir.
Hello.
Can
we go to the next talk?
Next talk like Guru.
Guru Prasad's talk like sir on the.
Okay. Guru Prasad ready ano?
Ready.
Yes, sir.
Next topic is oncological emergencies by Dr. Guru Prasad. Guru Prasad is well known to you. He's the president of Pediatric Hemato-Oncology chapter of IAP Kerala. And he has got a DM in Pediatric Oncology, and now he's working as an assistant professor in Pediatric Oncology, Regional Cancer Center, Trivandrum. His special interest is in critical care in neutropenics and pediatric hemato-oncological stem cell transplant. Regarding the topic today, oncological emergencies, cancer management usually starts with a systemic staging workup and planning. We also studied like that in undergraduate classes. But there are situations where immediate care and starting early treatment becomes mandatory. Such oncological emergencies can create a dilemma in routine practice. Before staging, we are forced to start treatment. situations like hyperglucosidosis, mediastinal mass with respiratory distress can create confusions like what next to be done. Now I invite Dr. Guru Prasad to elaborate on this pediatric emergencies and its dilemmas. Over to you.
Thank you, sir, for the introduction. Jitin, I can share slide.
1 minute. Yeah, given the privileges. Now start.
Okay. Is it visible now?
Visible.
Start. Okay. Let me extend my greetings from my sender before starting. And I'm thankful to the organizing committee, which I am also part of, for this opportunity. And I straight away go to the topic proper. So oncological emergencies are a very important part of management of oncology patients. So as Santosh sir rightly told during introduction, many of the time you may have to start your treatment even before you get the diagnosis, or at least start the supportive care aspect of it before your diagnostic workup plan is complete. So what is an oncologic emergency? It is potentially a life-threatening event that is either directly or indirectly related to the patient's cancer or its treatment. So the last two part is very important. It can be related to cancer at its presentation or any time during the course of the disease, or it can be related to treatment also. So that means it can appear at any point of time during cancer care, and you have to be very vigilant to recognize them at an early stage. So what are the common metabolic complications? We will be going through the topic under the following headings: metabolic, hematologic, cardiothoracic, and neurologic. Now coming to metabolic complications, the common ones are the tumor lysis syndrome, adrenal crisis, SIADH. There are other complications as well, like hypercalcemia, which are other metabolic complications which are more common in the adult patients. In pediatric age group, I believe these three are the common ones that we see. Coming to tumor lysis syndrome, as we all know, it is due to rapid death of the tumor cells releasing its contents. We all know the classic triad of tumor lysis syndrome, which is hyperuricemia, hyperphosphatemia, and hyperkalemia. And this hyperphosphatemia, actually, the phosphate bind with the calcium and cause a reduction in serum calcium, causing an associated hypocalcemia. This can happen before the start of treatment, when it is called a spontaneous tumor lysis syndrome, or after the start of therapy. Now, TLS can be classified into two: a biochemical TLS or a laboratory TLS, and a clinical TLS. Fortunately, the clinical TLS occurs in only around 4 to 8% of high-risk malignancies. And the following table gives us a chart to diagnose both laboratory TLS as well as clinical TLS. So laboratory TLS, if you have two of the following, we will take it as a laboratory TLS, but the patient may not be symptomatic due to any of this. Uric acid more than 8, potassium more than 6, phosphorus more than 6.5, and calcium less than 7, or a 25% change compared to the baseline values. When you have clinical TLS, you actually are pointing towards the end organ damages due to the tumor lysis syndrome, which is basically the kidneys, cardiac, and the CNS. Kidney presenting as acute kidney injury, cardiac presenting as arrhythmias, and CNS presenting as seizures. This is a pictorial diagram of TLS pathophysiology. once the tumor cells starts to lyse, the calcium phosphate are released. The phosphate causes the hypercalcemia. It binds with the calcium and causes hypocalcemia. Nucleic acids are released, which are degraded to uric acid and cause hyperuricemia. Potassium is released, causing hypokalemia. Calcium phosphate crystals as well as uric acid crystals precipitates in the renal tubules and cause acute kidney injury. So this can cause acidosis in addition to the lactate that are released from the tumor cells. So another dangerous situation is the situation of TLS actually produces acidosis, and this actually helps in the uric acid crystals to precipitate in the renal tubules. So both go synergistically. You produce uric acid and an acidic medium, helping the uric acid crystals to get deposited in the renal tubules. The calcium phosphate crystals actually precipitates in the alkaline medium, especially so when the calcium phosphate product is more than 60. These contrasting phenomenon has importance in therapeutic management of TLS, which we will come to. Both this leads to acute renal failure. So what are the tumors at risk of TLS? Tumor with high growth fraction, large volume, wide dissemination, and the next point is very important, tumor that is very sensitive to chemotherapy. So when to suspect? If you certain malignancies are prone to TLS, you have a wide range, but in pediatrics, the common ones are Burkitt lymphoma, lymphoblastic lymphoma, as well as TALL, which presents with hypoleukocytosis. Other situations include pre-treatment high uric acid level, high LDH, a pre-existing renal issue, and an older age group. Clinical features include abdominal pain, which is usually due to abdominal cramps, due to the electrolyte imbalance, vomiting, cramps, muscle cramps, spasms, tetany, seizures, and alteration of consciousness. Now, how do you work up? A baseline workup, of course, will include a CBC. In addition to that, you send a tumor lysis TLS panel, which will include a renal function, a uric acid, calcium, phosphorus, and potassium level. You send an ECG to look for evidence of arrhythmias. This is an important part of TLS workup. You should always go for a USS ultrasound to look for a pre-existing renal anomaly or a pelvic mass causing an obstructive AKI, because the TLS itself will be causing AKI. So you should be knowing whether the patient is already having some renal issues or the tumor itself is causing AKI by another way, like an obstructive AKI. If it is an obstructive AKI, do a catheterization. You can relieve the AKI, you can decrease the AKI component, kidney injury component that is due to the obstruction. Also, if there is an obstructive uropathy, hydration, which is an important part of TLS management, will cause the obstructive uropathy to exacerbate once you start hydrating. Now, coming to management, as I told now, hydration is the most important part of management. You have to give a high volume fluid in the range of 2 to 4 times the maintenance volume. What we routinely advise is around 3 liters per meter square. You have to maintain a pH between 7 to 7.5 to ease the excretion of uric acid, because uric acid is more soluble in an alkaline urine. Urine output should be monitored very closely. Every 4th hourly, you should look into the IO chart and monitor urine output at the range of around 100 ml per meter square per hour. The role of diuretics and mannitol should be used judiciously, especially in the setting of hyperleukocytosis. Now, what fluid and should we alkalinize? Most of the classic textbooks in pediatric oncology says you can give 1/4 DNS, especially this mainly to decrease the sodium load. But there are many articles now published where they say even a isotonic saline is sufficient, provided you are maintaining a good urine output. Whether to alkalinize or not. Alkalinization definitely helps in excreting the uric acid, but the concern is it will cause precipitation of calcium phosphate crystals. This is especially so when the pH goes above 7.5, and the pH above 8 will cause precipitation of hypoxanthine and xanthines that accumulate, which accumulate when we give allopurinol. So alkaline pH definitely has its risk. Alkaline urine definitely has its risk. In our center, we used to do alkalinization, but currently we have stopped doing it. We just hydrate. We don't alkalinize now. Allopurinol is given at a dose of 10 mg per kg per day in 2 to 3 divided doses. Urate-oxidase, which is an enzyme rasburicase, which directly destroys the uric acid. So allopurinol only prevents further formation of uric acid, but it does not act on already formed uric acid. But the use of rasburicase, an enzyme that converts uric acid into allantoin, which is a very soluble form of uric acid, and one that does not need alkalinization to excrete also. So that is the role of rasburicase. There are certain malignancies where you prophylactically give rasburicase, where you classify the situation into high risk and low risk and decide on the role of rasburicase. The dose is around 0.2. The points to be kept in mind while giving rasburicase is that, one, it is a protein, it is an enzyme, so you have to be ready to manage anaphylaxis reaction. Also, the patient should not be having G6PD deficiency. Now, hyperkalemia. What we do routinely is once the sister call and tell there is high potassium value, you tell them to start nebulization, and you send for an ECG. You don't wait for an ECG result or anything to start your treatment. You tell them to alkalize your fluid and monitor the urine pH to keep it below between 7 to 7.5. Glucose insulin infusion can be given. Potassium binding agents like KX-Lite can be used, and most of the time in situations where you expect TLS, you would have already told the potassium restriction in their diet. Now, the role of calcium gluconate, you should use it very judiciously, because when you give calcium gluconate, you are giving an agent that can bind with the phosphate that is there due to hyperphosphatemia and cause precipitation of calcium phosphate crystals. So use it judiciously, maybe keep it as the last option. When you're feeling you need membrane stabilization, where you have an arrhythmia. As I told, hypocalcemia is treated only if it is symptomatic, and an asymptomatic hypercalcemia is just observed and monitored for arrhythmias. Now, coming to adrenal crisis. So this happens usually in a patient who's on treatment. So who are the patients who are likely to get adrenal crisis? Usually in management of leukemia, it is a steroid exposure. And it has been said that the adrenal failure persists up to 7 weeks post-steroid exposure. Other causes include an intrathecal hydrocortisone, and most of the leukemia malignant patients are on fluconazole for some reason, like prophylaxis or for treatment purpose. And it has been reported that fluconazole actually prolongs the adrenal suppression. Apart from the typical clinical presentation, which usually presents as lassitude, weakness, or refractory shock if the patient happened to develop shock, the biochemical parameters that should be looked for are hyponatremia, hyperkalemia, and normal anion gap metabolic acidosis. The treatment, as we all know, is giving a bolus of steroids in the form of hydrocortisone, steroid with mineralocorticoid action. The dose that we commonly use is 100 mg per meter square as loading, followed by 25 mg per meter square 6th hourly, and stop for 7 days and stop. CR is common in intracranial lesions like medulloblastoma, lymphoma, olfactory neuroblastoma as part of paraneoplastic manifestation. It can be part of treatment like vincristine, alkylating agent like ifosfamide, cyclophosphamide, platinum derivatives. So you diagnose CR by looking at the urine osmolality, serum osmolality, urine sodium, and urine sodium. Also ruling out other causes for the hyponatremia. Should not be there when you're diagnosing SAADH. Coming to management of SAADH, it is mainly fluid restriction. We set the fluid restriction at around 2/3 to half of the maintenance fluid. Sometimes we may have to go down to around 1/3 of the maintenance fluid. If you have a neurological manifestation, apart from fluid restriction, you have to supplement the low sodium with 3% saline to bring the sodium up to around 120. Also, you have to diurese the free water out by using furosemide. Coming to hematological. Now coming to hematological issues. The most common one is the most important one is the hyperleukocytosis. So the definition is
आपकी मूछें अच्छी हैं.
The definition is around more than 1 lakh, but more than the number 1 lakh.
Fuck me in my pussy.
More than the definition 1 lakh. It is the type of malignancy that is more.
I need the fucking water. Give me the fucking water, you bitch. Nigga, stop muting me, bro. Stop muting me, bro.
Guru Prasad, cheers.
Stop muting me, bro.
Guru Prasad, cheers. Niggers.
More than the number 1 lakh, it is a type of malignancy that is more important from a management purpose or a symptom purpose, because from a symptom, an AML can be more symptomatic at a lower WBC count, like around 1 lakh to 2 lakh, because the AML blasts are more larger and more stickier compared to a lymphoblast, where the patient may not be symptomatic even when the blast count is around 3 lakh. Jitin, I'm not able to move the slides.
1 minute, Guru. ഞാനത് സെറ്റിൽ ആക്കാൻ നോക്കുന്ന.
Fine. Take your time.
Madam.
can proceed, no, Guru Prasad?
Can I, Jitin? Please, madam.
Yes, you can
I'm not
proceed.
able
You
to
can proceed.
go ahead in the slides.
Guru, please proceed. Hear me?
Jitin?
Yeah, Guru Prasad, can you hear me?
Yes, I can hear, sir, but the slides are not moving. It is stuck.
It's a small issue with hackers. I'm just removing one by one.
Guru, ഒന്നുകൂടെ restart ചെയ്യോ sharing screen?
Okay, let's get back. Hematology. Hyperleukocytosis. So the definition of hyperleukocytosis is count more than 1 lakh. However, many of the time they may not be symptomatic at a count of 1 lakh. It depends on the type of malignancy. AML may be symptomatic at a lower count, which is hyperleukocytotic. Around 1 lakh to 2 lakh, they may become symptomatic, but ALL lymphoblast may become symptomatic only once the count is usually above 3 lakh. What are the complications due to this hyperleukocytosis? They mainly affect the CNS due to CNS leukostasis causing confusion. Sometimes small capillaries, the blood may get clogged and cause rupture of the capillaries causing CNS bleed. Pulmonary leukostasis causing hypoxemia, metabolic derangement as in tumor lysis syndrome. Priapism, clitoral engorgement, dactylitis are common rare complications. The management is basically similar to that of tumor lysis syndrome. The most important part of it is hydration. So whenever you are working in any center, you come across a child with hyperleukocytosis, and your center is not able to manage or work up the patient before referring or while transporting the child. The patient should be started on fluids. When you're starting fluids, avoid a fluid that contains potassium. The common one that is routinely available is the ringer lactate. Don't put ringer lactate to hydrate, or I mean ISOP to hydrate these patients. A normal saline or a DNS will suffice. Another thing that you have to do is correct the platelet. If platelet is less than 20,000, bring it up. Try to keep it above 50,000. Another important point is if the child is having hyperleukocytosis, that means marrow is well infiltrated. Marrow may be infiltrated and hemoglobin will be less. you will be having a tendency to give blood PRC or packed red cells. The issue with giving packed red cell is that it will increase the viscosity of the blood and predispose to more thrombosis. So you should transfuse only when the patient is having a symptomatic anemia. Also, when you are transfusing, try to give it over a longer period, like a 4-hour transfusion, and give at a lower volume, not the routine 10 ml per kg, give around 5 ml per kg. Exchange transfusion or plasma leukapheresis has its role, but the role has always been debatable, and it is not available in most centers. AML M3, this is for an oncologist perspective. For a pediatrician, it may not be that important, but I feel pediatricians should also be knowing, especially those working in a tertiary care center. AML M3 is also considered an oncologic emergency. If you come across an M3 and your referral center is far away, like a 6-hour, 12-hour travel, probably you should start all the supportive cares, like giving platelet concentration, correcting of coagulation parameters with FFP or cryo, whichever is available, correcting anemia. And the most important thing is, if the pathologist has called you and told it looks like a promyelocytic leukemia, better to start all trans retinoic acid at 25 mg per meter square if it is available in your center. Because M3 is a medical emergency and they can bleed at any time. Coming to cardiothoracic complications. It can be superior vena cava, mediastinal syndrome, pleural pericardial effusions, massive hemoptysis, pneumothorax, etc. The term vena cava syndrome and mediastinal syndrome are more relevant from an adult perspective. Vena cava syndrome is compression of vessel alone, and mediastinal is, in addition to vessel, compression of airways. But pediatric trachea, being a more pliable structure, they will be compressed usually when in an early stage. So vena cava and mediastinal syndrome usually we don't distinguish. It is almost always mediastinal syndrome. The malignancies commonly causing this include, the most common is lymphoma, leukemia, Hodgkin, and Ewing sarcoma are common. Other causes of vena cava syndrome include vascular thrombosis, which can be due to a central venous catheter, and certain chemotherapeutic agents like L-asparagines. As we know, there can be obstructive symptoms symptoms due to carbon dioxide retention as well as venous stasis. Now, the points for a pediatric perspective is that when you have a mediastinal syndrome, try not to keep the patient for a long time in a supine position, especially for an abdominal examination, or when you're sending for a CT. If you're sending for the CT, do mention in the request that the CT needs to be taken in a prone position, which may, because in the CT room, the patient is alone for the time the CT is being taken and you are not able to monitor it. So better to keep the patient in the prone position. Another important position is if you are if you're feeling that the patient is acutely sick and there is an impending respiratory failure and you want to start some steroids or some form of treatment, and you want to take some specimens before starting the treatment, try to do the procedure like bone marrow or a biopsy in a sitting position. Try to avoid the routine fetal position that we adopt during bone marrow procedure. Try to avoid sedation and try to do this in a with a good local anesthesia. So a chest X-ray, CT in a prone position, echo and Doppler to look for thrombosis in the vessels, and obtain a specimen before starting steroid. This is a simplified approach to a mediastinal mass. So if you suspect a superior vena mediastinal syndrome, take a chest X-ray, you have a mass, send a CBC and a peripheral smear and TLS parameters. In addition to this, what we routinely do is we send an alpha fetoprotein as well as beta HCG, especially if the patient is an adolescent, to look for germ cell tumors, which can also present as mediastinal syndrome. If any of this is diagnostic, treat accordingly. If these are diagnostic, probably you may not need a biopsy from the mediastinal mass. If these are not diagnostic, then you have to give support, give all the supportive cares. You have to assess the patient for anesthesia risk. If the patient is low risk for anesthesia, do a biopsy, treat accordingly. If the patient is high risk for anesthesia, give supportive care and stabilize the patient, like giving PRC, oxygen, positioning the patient, platelet transfusion. After all the supportive cares, reassess the patient for anesthesia risk. If If the patient now becomes low risk for anesthesia, or at least you can do under a local anesthesia, do a biopsy and treat accordingly. If the patient is still high risk, then there is role for something called a gentle chemotherapy. Most of the time, pediatric cases and anterior mediastinal mass respiratory syndrome is almost always leukemia lymphoma. So the drug that we usually give as first line is a dexamethasone. But if you're planning to give dexamethasone, always start TLS supportive care along with it. If it is not responding to dexamethasone, it may be a solid tumors, in which situation we may need drugs like cyclophosphamide, vincristine, and anthracycline. But when we are giving a gentle chemotherapy, you should be aware that the diagnosis may become difficult after that. Once you start this, the patient should be very closely monitored, and the first point of time when he becomes low risk for anesthesia or low risk for a local anesthesia, a biopsy should be done. The situation where the patient does not respond is teratoma, large cell lymphomas, germ cell tumor, benign tumor, or an extensive thromboembolism, where your steroid would have brought down the mediastinal mass, but if the symptoms are still persisting, maybe the thrombus is still persisting. That is causing the symptoms even after the mass has disappeared. Pleural and pericardial effusion is also a common presentation, but in a malignant setting, an asymptomatic effusion may be left alone and go ahead with the treatment of primary tumor. A single therapeutic tapping may suffice, because once the treatment is initiated, the fluid is absorbed by itself. Hemoptysis. This is an important complication, especially in a patient who is on treatment. This is due to cavitary lesions caused invasive cavitary lesions caused by aspergillosis, staph, Klebsiella, and Pseudomonas. From the management perspective, for a pediatrician, the most important thing is, if you have the lesion on on one side, you have to place the patient in a lateral position and place in such a way that the side where the lesion is there should be on the lower side, so that the blood does not pool into the normal lung. An intubation may be needed to prevent asphyxiation by pooling of blood into the normal lung. Also, parallelly, you have to correct thrombocytopenia and coagulopathy in an aggressive manner. Pneumothorax need to be managed. Most of the time, this will need a chest tube, because pneumothorax is mostly due to a fungal cavity bursting into the, or a metastasis that is bursting into the pleural space, that may not be managed by a simple needle thoracocentesis, but needle thoracocentesis can be done for an immediate care. Now, coming to neurologic complications, common one is the spinal cord compression. In addition to this, I would also suggest mass in the orbit that is causing visual compromise is also a neurological emergency, because this can cause permanent impairment, both neurologic and vision loss. Common causes include metastasis from sarcoma, neuroblastoma, germ cell tumor, Ewing's, leukemia, etc. Presentation include pain, bladder, bowel issues. Investigations, you may diagnose this on a chest X-ray, but most of the time you will need a imaging like CT or MRI. Management, usually a medical management consists of giving steroids to decrease the edema part of the tumor, and aggressive workup for diagnosis and initiation of treatment that is directed towards the primary disease. The steroid is given usually at a higher dose. We give at a dose of 1 mg per kg per day, that is 0.25 mg per kg per dose 6 hourly. Other modalities of treatment that may work include local therapy as well as surgical decompression. So coming to seizures, so the cause of seizure can be due to the primary malignancy itself, like CNS tumors. It can be meningeal leukemia, anti-leukemic therapy like intrathecal therapy, high-dose methotrexate, SIADH. Radiation can sometimes be predisposed to seizures, and metabolic derangement that is seen in tumor lysis, as I told before, in tumor lysis. Management of seizure is like any other pediatric situation, but one point that we tend to differ from a routine pediatric setting is when we start the anti-epileptic agent, which is to be used for a long time, we usually do not prefer phenytoin or phenobarbital. We usually prefer levetiracetam, because phenytoin and phenobarbital has shown to have a significant interaction with chemotherapeutic agents, and because being enzyme induced, they may decrease the efficacy of chemotherapeutic agents that may have effect on the survivor. So, Thank you.
Thank you, Guru. I think
you are also there in the picture.
Santosh sir and Santosh sir. Okay, sorry for all this trouble. Somebody hacked in between and made all this trouble. I think if
don't talk about that, leave it.
Eh?
Don't talk about that, leave it.
If any questions we can answer right now, or we can move to the next session, next topic. Okay.
Jitin, should I start now or are we waiting?
Yeah, we can start.
Okay. Is my screen visible now?
Yes.
Okay, good. Okay, sorry for the initial technical glitch, but I think Guru has, mine actually is a preamble or a prelude to Guru's presentation. I think Guru has explained it elaborately, so I'll take you through a fast slideshow about what are the varying presentations. So, pediatric leukemia, has been a model for cancer research and treatment, and from cure rates less than 20% with the contemporary treatment protocols, cure rates have gone up to 95% in some of the well-controlled clinical trials in the Western world, and even in India with the contemporary treatment protocols, we have an average of 70% survival. And they say the best way to learn or study a variable disease in variable human beings is to study the variable disease in variable human beings. So pediatric leukemias, as you know, as pediatric postgraduates doing our residency, we always knew that with fever, hepatosplenomegaly, lymphadenopathy, bleeding manifestations, leukemia or malignancy was always on the one of the top differential diagnosis, and we always used to have that one clinical examination. We used to look forward the sternal tenderness or the bone tenderness to differentiate leukemia during those times. But the horizon is actually vast but finite, and the clinical manifestations are not that much enormous in pediatric leukemias. It's more or less straightforward in many cases, but yes, there are a couple of them. I will give you a glimpse of those. So usually they are divided into acute and chronic depending upon the duration and the rapidity of onset, and according to the lineage affected, myeloid and lymphoid. We usually see in pediatrics AML, ALL. ALL is 80%, AML is 20%, CML is 2% of the leukemias. CLL is usually an adult neoplasm. And this is usually the epidemiology. As you can see, with regards to ALL, it's usually seen in childhood. Usually the peak age of onset is around 2 to 4 years. That's the maximum incidence, especially of BALLs. And then towards adolescence, we have a higher incidence of TALLs. And in AML, on the other hand, the incidence actually increases with age. As you can see from infants, there is a higher incidence in the children, and after that it comes down. In adolescents there is a slight increase, and after that there is a rise in the incidence of AMLs. So what are the clinical manifestations of leukemia due to? So what happens in leukemia is there is the expansion of these abnormal blasts in the bone marrow, and because of this expansion, they suppress the normal hematopoiesis, and hence the normal blasts and the maturation into the committed cells is affected. And hence we have the predominant manifestation, which is that of bone marrow failure, manifesting as cytopenias, affecting all the 3 lines usually, and sometimes 2 lines. So, and the remaining manifestations are usually due to the extramedullary infiltration of these leukemic blasts causing organomegaly, which usually manifests commonly as hepatosplenomegaly and lymphadenopathy, which we are all aware of. And we can have chloromas, leukostasis, as Guru has also pointed out. So if you look at the broad symptomatology, these are mainly what we see in the Indian population, and this data is from the St. Jude. So as you can see features of bone marrow failure in 80% of them. Pallor is usually seen in around 90%, and the anemia that you see in these children are usually normocytic, normochromic, with a normal to low reticulocyte count, unless it is compounded by other malnutrition and nutritional deficiencies. Usually around 80% of them have fever, and fever in them, 2/3 of them is due to the disease per se, due to the release of interleukins, especially interleukin 6. And you also have to know that because the abnormal blasts are proliferating, there is severe neutropenia, and whatever neutrophils are there are also functionally abnormal. So you have to start broad spectrum antibiotics in these patients until you have a blood culture which says negative. And usually if it's disease fever, with the start of your therapy, within 3 days, the fever subsides. And bleeding is also seen, and you can see as petechiae, purpurae, or submucosal bleeds also. But severe IC bleeds are usually rare even at low counts, unless there are other compounding factors like increased WBC count. The extramedullary infiltration, as you can see, lymphadenopathy in our children are usually seen in a majority of them, especially the B and the T ALLs. They can predominantly come with bulky lymphadenopathy, and also the monocytic AMLs. Half of them or 2/3 of them have hepatosplenomegaly. So if you look at the Western population, you can see in them only around 1/3 of them present with huge hepatosplenomegaly, compared to around 2/3 of our patients. And hence, even in the ISECL, the Indian collaborative protocol, hepatosplenomegaly more than umbilicus is taken as a risk higher than the normal patients and are treated as intermediate risk. This bone and joint pain, I always remember, because even as pediatric residents, Dr. Purushothaman sir used to give us this DD, because we were all excited about juvenile idiopathic arthritis, and he always used to say, a patient presenting with arthritis, you should have malignancy and ALL as your DD. And this is usually due to the infiltration of the bone marrow into the periosteum, which is the painful structure, or the expansion of the marrow causing periosteal expansion. It can also be due to this thrombocytopenia causing subperiosteal hemorrhages and expansion. Mediastinal mass, you can see CNS and testicular disease in the contemporary treatment protocol with effective systemic therapy. It's usually seen only in a lower percentage of the patients. So these are the usual manifestations which all of you are aware of: wet bleeds, dry bleeds, lymphadenopathy, pallor, as you can see, and hepatosplenomegaly. These are the usual common manifestations we see around as our pediatric residents. And if you see the blood, you can see there is cytopenias. This is a case of pancytopenia. This is actually bicytopenia, but the WBC counts are high here. So this child actually presented with arthritis. You can see it can be knee or hip arthritis, and most of the time these children are treated with IV antibiotics as septic arthritis for a long time, and the CPC counts are usually overlooked into. So this always should be a differential in our mind whenever we come across such patients. So as Guru has also pointed out, mediastinal mass at presentation actually is seen in T lineage lymphomas and leukemias. More than half of these patients, 50 to 60% of them, have an associated mediastinal mass, and in some cases will be asymptomatic, but most of them are usually symptomatic. And as you know, because this mediastinal mass, this is seen in T because the T cells mature in the thymus, and in T cell ALL, usually the abnormality happens in the thymus, and the abnormal blasts proliferate in the thymus, and hence there is an expansion of the thymus causing an anterior mediastinal mass. So this can be symptomatic, and as you can see here, the symptoms are due to the tracheal and the bronchial compression, which can manifest as respiratory distress. And as you know, there is a SVC here which get compressed, and hence, since the SVC is a drainage area of the head and the upper limb, there is venous congestion in these areas with plethora. There can be cyanosis. There is facial edema and upper limb edema with dilated veins due to the collaterals, which are manifestations of SVC syndrome and is an emergency. As Guru pointed out, emergency airway management. Position is very important. Propped up, left lateral or prone position. Even to change the clothes, you put him flat for even 5 seconds. That could be the end of it, because sudden cardiac arrest is known in these patients. And the IV lines always in a patient with mediastinal mass has to be in the lower limb, because you want it to go through the IVC and not through the SVC and congest it further. Now, if most of these mediastinal masses in T involvement are usually associated with pericardial and pleural effusions. You can see here pleural effusions, and in this patient there is a straight hard border, which is usually a pericardial effusion. And we have to be very cautious in this, because these patients might need preemptive pigtail insertion, especially those with pericardial effusion, which is moderate to massive, because cardiac tamponade is life-threatening and gives no time for intervention. These will require a preemptive pericardiocentesis, and they can accumulate further, and hence a pigtail in situ would be the ideal thing to go. And hydration, everything has to be managed. And as Guru pointed out, no GA in these patients with syndromes. As much as possible, only local anesthesia should be attempted to obtain a diagnostic procedure. In higher centers, mostly when you have associated infusions, you can send the fluid for flow cytometry, and which gives you a result within 24 hours. Otherwise, you can look at the blood tumor markers, or in the end, the last resort is mediastinal mass biopsy. It should be under local, or if the child is intubated, you can go ahead with it. And this testicular involvement usually used to be a lot in the earlier era, but nowadays it's seen less. Only overt testicular disease is seen only in 2% of the ALL, usually seen in infants who have the MLL rearrangement, or in the adolescents with T-cell disease. They are more seen. It manifests as a painless enlargement of the testis, and it is usually a DD is varicocele or a hydrocele, usually a hydrocele in infants, or epididyma orchitis, but usually those are painful, the epididyma orchitis, but this is a painless enlargement of the testis. And when you do a USG scrotum, you can see the altered echo texture and the increased vascularity in such cases. The testicular disease is no longer a high risk with the contemporary effective high-dose methotrexate and systemic chemotherapy. But on the ICYCLE protocol, we usually take it as intermediate risk. And not all patients require testicular irradiation unless there is persistent enlargement, which is shown to be persistent disease on biopsy or otherwise. CNS disease is due to another, as you all know, these testis and CNS are known as the sanctuary sites, because you have the blood testis and the blood-brain barrier there. And it is very important to direct therapy towards these sites. Otherwise, the chances of relapse in these as isolated or combined are very high. Only 2% of our children with ALL have overt CNS disease at presentation, and most of this is detected during routine CSF examinations that are part of the risk stratification in upfront cases. And they can also present with cranial nerve palsies, and these cranial nerve palsies are usually the element type of facial palsies because of the infiltration around the nerve sheaths. So this child has a right element facial palsy. Most common, as I've said, is a CSF examination showing a blast on the centrifuge sample, and also there will be white WBC counts on the CSF. And they can also present as optic nerve thickening or optic nerve involvement causing pain and visual blurring or vision difficulties. There are other manifestations where you can have the malignant cells in the anterior chamber presenting as hypopyon here. This is usually not seen in upfront cases and mostly seen in relapse cases. But you can have leukemic infiltrates in the retina causing difficulty in vision and pain. And then that can manifest as, if you look at the fundoscopy, you can see the disc edema. You can have leukemic infiltrates and hemorrhages with a white center, which is typically seen in leukemic infiltration of the retina. Now, as I've pointed out, there can be manifestations due to other organ infiltrations, and some things to note are the involvement of the kidneys. The kidneys can sometimes be bulky, and this is very important to know in a sense that if the child has renal involvement, Because as Guru pointed out, the thing of the concept of tumor lysis, where the tumor cells lyse, necrose, and sends out potassium, uric acid, which are all handled by the kidney. So if your kidney also is involved by the leukemia, this handling of the metabolites can be a problem, and the child can have an exaggerated tumor lysis syndrome warranting hemodialysis. So you have to be aware that if there is a renal involvement, and the BP can also be high, and the patient can go into hypertensive crisis and press. So these patients should be closely monitored for TLS. But treatment has to be given only if you give treatment will the leukemic involvement also go away. So they have to be closely observed and monitored for TLS. So this involvement of the skin, which is a fancy for a lot of us pediatricians, which is it can be seen in ALLs, and usually see in infant ALLs who have MLL gene rearrangement known as leukemia cutis when you have the skin involvement. This is one of the DDs is neuroblastoma causing blueberry muffin lesions also. So these children with MLL rearrangement usually have a poor prognosis regardless of the therapy you give. Rarely you can have other organ involvement. This child have a parotid enlargement manifesting as Nicholas syndrome. Now, this is the commonest things that we look into when you have a child with fever, bleeding, manifest cytopenia, megaly. So the CBC. So CBC is our main investigation, and you can see here the child has pancytopenia, anemia, thrombocytopenia, and neutropenia. And when a peripheral smear and a manual differential count is seen, you can see there are blasts, 81% blasts, and you can do the MPO and the NSC stain also, which will differentiate the morphological forms of monocytic and M2 and M3 leukemias. Now, blasts can be seen on the peripheral smear, but even despite this, it is very imperative to do a bone marrow aspirate and a bone marrow biopsy in patients, because if you don't see blasts, definitely, because leukemic leukemia can be seen in 10% of the children, and aspirate should always be combined with a biopsy, because the counts are high, the marrow can be very packed, and you might not get a good aspirate, but the biopsy will show these clusters of blasts. And why I say the bone marrow aspirate and biopsy is important is because the cytogenetics is an important part of risk stratification, which helps to tailor therapy in these children to optimize cure. Some of these children can have hypoeosinophilia, especially the ones with translocation 514 and also the AML with inversion 16. And this hypoeosinophilia can manifest as hypoeosinophilic syndrome with pulmonary cardiac infiltration and cardiac failure, respiratory failure. You can also look at the LDH, which will give you an indication of the leukemic tumor burden, and those with high LDH has to be monitored closely for tumor lysis syndrome. So as part of your routine investigations, when especially a child who has bleeding manifestations, you have to get the coag, including D-dimer and fibrinogen. And this severe coagulopathy can be the manifestation of APML, or it could be also due to the DIC seen in association with sepsis. So this is a biochemistry panel of one of the patients who came with suspected leukemia. And as you can see, here the LDH is high. Some of them have thousands and 4,000s LDH. This is high though. And you can also see here the uric acid is increased. It's 44. It's very high. The creatinine is increased subsequent to that. The potassium is also on the higher side. And you can see the phosphorus is also high. So this is a case of classical tuber lysis syndrome. This tumor lysis syndrome can be spontaneous, or it can seen after the initiation of therapy up to 1 week. So you have to closely monitor this patient. In all cases of suspected leukemias, you can start the anti-tumor lysis measures. Start off the xanthine uric acid inhibitor allopurinol, the phosphate binder gelusil. Gelusil has to be given with food. We are not using it as an antacid, where it has to be used on an empty stomach. Dietary advice is an important, where initially when you see fluids, plenty of oral fluids, high potassium, high phosphorus diet has to be restricted at least for the initial week. So these are the things that we can do even at the first point of contact at any level of care. Now, this is one condition, one presentation that Guru has also pointed out. You can see here cytopenia, and in addition to that, you can see that the WBC count is in the order of lakhs, 2.3 lakhs, and this is what we call the hyperleukocytosis, where the WBC count is more than 1 lakh. This is important to know because of the complications that are associated with hyperleukocytosis. Mainly, we are concerned about leukostasis, and this leukostasis is due because to the reason there are two theories regarding this. One is the hyperviscosity, because there is increase in the WBC count. The viscosity of the blood is increased and it will clog the microcirculation. One other theory is the blast secrete a lot of cytokines, which causes adhesive factors to be expressed on the endothelium, and hence these bind and cause occlusion of the capillaries, and the organs which are most commonly affected are the lungs, CNS, and the kidney, which are the vital organs needed during such a condition too. So this is a problem with hyperleukocytosis, and when the lungs are infiltrated, the child can have respiratory distress, cough, dyspnea, respiratory failure. You can see the interstitial infiltrates of the leukemic cells, and in the CNS, you can see these bleeds which can manifest, and they can come with altered sensorium, and that could be a problem. And hence, it is important, and also one of the other manifestation is priapism. More so, it is seen in chronic myeloid leukemia. It is due to the dorsal vein occlusion. The corpora cavernosa becomes stagnated with blood. This can be very painful, and some of the therapies are very difficult to control this. As Guru pointed out, leukophoresis has not shown to be evidence-based strong utility in such situations, and it is a definitive therapy that's most commonly going to help. So this hyperleukocytosis requires hyperhydration, 3 liters per meter squared per day, anti-TLS measures, platelets keep it at a higher titer because we don't want hemorrhage, especially intracranial hemorrhage. Keep the threshold for hemoglobin up to 5. Don't transfuse above 5. Below 5, you can give it in small aliquots. Be careful about usage of diuretics because it can contract the intravascular space and cause hyperviscosity. Cytoreductive measures has to be started immediately. You can use, there are various, if you're suspecting AML, you can start hydroxyurea, otherwise you can start steroids with close monitoring for TLS. So this is another child who presented to us. Again, the CBC showed cytopenias, and when we did the biochemistry, the rest of the tumor lysis parameters were all normal, but if you see, you can see the calcium is high. So this child had a PET CT done outside, and you can see the different lytic lesions in the bone. So this is a hypercalcemia, which is seen in around only 0.5% of our patients, but this can be distressing and can be very symptomatic. Seen more so in adolescents, and especially those with translocation 17-19, which carries a very dismal prognosis. Can be due to the PTH-related protein or due to the bone lesions. Steroids are very useful. Mostly it settles with steroids and furosemide only, and sometimes we have to give calcitonin. Zolitronic is only very rarely used. So this I am sure everybody would be familiar in one of the X-ray classes by Dr. Ananda Keshavan. I've seen it many a times. This is leukemic infiltration into the bones manifesting as metaphyseal lucent bands. You can have sclerotic lesions, lytic lesions in the bone. So these are seen in 50 to 60% of the cases. If you take an X-ray, you can see these manifestations, usually not symptomatic. 2% of them can present with symptomatic bone involvement where the symptoms are due to the compression fracture in the vertebra. They can have severe back pain, and this requires only supportive care, and you should start the therapy. In many of these cases with bone pains, starting therapy relieves the pain and makes the child well. This is what we were talking about. This is a child who has bilateral proptosis. You can also have unilateral proptosis. These are the classical chloromas or the extramedullary myeloid tumors or the myeloid sarcomas that you see in AML. So this is the first child. You can see the whole mass has displaced the eyeball behind, and the child has no vision. It's mainly due to this mass behind. It can also come in the spine as a paraspinal deposit here, causing cord compression and acute paraparesis. These are usually seen in good biology leukemias like the 821 and the inversion 16. They can also be seen in the MLL rearranged leukemias. The treatment, irrespective of whether the marrow is involved or not, is like that of an acute myeloid leukemia. If there is threatening organ function like vision and paraparesis, you can give low dose RP, a fraction 4 gray or a 6 gray, low dose RP in such cases to preserve the function, and you should start definitive therapy at the earliest. So this is another child. You can see she has bilateral proptosis due to chloromas, and you can see the skin infiltrates here, and the infiltration of the neck nodes, which is ulcerated. These are typically seen in AMLs with monocytic differentiation. When you do a peripheral here, you can see blasts which are MSC positive. In monocytic leukemias, there is a lot of organ infiltration. This can any organ can be affected, and they can come also with persistent diarrhea too. So this is another thing which all of us would have been fascinated at the pediatric residency level. You can see the myeloblast with the classic OR rods there. And if a child has this on a smear and has come with predominant bleeds, coagulopathy, APML should be a first diagnosis, and the child should be started on ETRA if it's available, or arsenic if it's available, pending definitive diagnosis. Because unless you control this, the chances of intracranial bleed in these children are high, and the survival rates, if you treat them properly early, are as high as 95% to 100%, and you lose most of these children due to early hemorrhage, and the mortality can go very high in such. So if the first month is overcome in these children, the survival rate is above 95%. These require, as Guru said, FFP and platelet support should be started at the primary point of contact only. So this is a happy child, Down syndrome child. He's not that happy because these children also, you can have leukemias, and leukemias are the 2/3 of the malignancies are leukemias. These children, unlike the normal population, they have higher incidence of AML, especially in less than 4 years, they can have AMKLs. But the good thing about these leukemias are highly curable with just cytarabine therapy, and can receive, reach up to 86% survival, which is not usually seen in other types of AML. So these are the happy leukemic patients we are very comfortable to treat because if AMKL GATA mutation, the survival chances are very high. So apart from manifesting as cytopenias and organ infiltrations and the symptoms subsequent to that, we can also have patients who come with severe bad infections which you don't suspect in an immunocompetent patients. These are usually seen in immunocompromised patients, either part of an immunodeficiency, primary or acquired, or due to leukocyte or phagocytic dysfunctions. So some of these leukemic patients, especially the one with myelodysplastic syndrome and myeloproliferative neoplasms, can manifest with such atypical infections and severe infections. This child had a fungal sinusitis. If you see the oral cavity, you can see it is invading the bone, the palate, and such a thing is usually a fungal, usually more mucormycosis, and requires intensive supportive care. This child also had an associated fungal pneumonia. You can see these ground glass opacities, and when he was given therapy, it usually responds with a classical sign that you see, the fungal balls, the crescent sign and the fungal balls. So this is something that it's not very common to see these days. The gingival hypertrophy, which is seen in AMLs, usually the monocytic, and also in the 821s you can see. Some of them have bad herpes lesions involving the lips and the tongue. So anything unusual than what you see in the general population, immunodeficiency or some phagocytic dysfunction should always be in the back of your mind. JMML, just a few lines. This is usually constitutes 2% of the pediatric leukemia seen in less than 4 years of age. Monocytosis on peripheral smear with a shift to left is the predominant picture. You don't see much of blast. There will be cytopenias, but shift to left and absolute monocyte count more than 1,000 and a huge spleen. In such a child should ring a bell regarding JMML. Because for these children, doing a genetic testing, cytogenetics is important to prognosticate and plan therapy, because some of them can spontaneously resolve, some of them will not resolve unless there is transplant. There is no other treatment for this. Transplant is a definitive treatment for such patients who cannot be observed. There are a lot of DDs to that, but I have to tell you before we end, whenever you have a child with suspected leukemia, you also have to look at other points which other neurocutaneous markers or pointers in the examination of history, which points towards a hereditary cancer predisposition. Because if you don't look, you won't see them. And in pediatric malignancy, up to 10% can be due to a cancer predisposition. And in leukemia, certain leukemias have a higher predisposition. So what you have to ask is the family history, and having a family member, first degree or a second degree or a third degree member with a malignancy before 40 years. 40 years is a cutoff. And if you have a malignancy at an earlier age, it should always point towards a suspicion of cancer predisposition. So this is one of a child came with ALL, but there was a family history in the previous generation of breast carcinoma, and it was less than 40 years, that is premenopausal breast sarcomas. In this child with consanguinity, you can see one generation whole has been affected, and all types of leukemias have been there, and it's very distressing for us also to treat these patients, and for the parents also to come up with subsequent consecutive children with such malignancies to the department. And this is another child again. You can see he lost one child first. Second child was diagnosed, transplanted. He is now surviving. Now the third child is also having a leukemia and is awaiting transplant. And one of the other child has Joubert syndrome. So it's a very distressing family. And it is important for us to see for those subtle manifestations. Café macules as NF1 can also have leukemias, and JMMLs, especially when you have a JMML, look for NF1. This is one of the entities, constitutional mismatch repair deficiency. They can have café, and these people can have early onset leukemias, and also Fanconi can also have café. Fanconi usually has AML more of ALL. CMMRD can have leukemias. This is important not only for the child, but also for the family, for genetic counseling, screening, and because there are surveillance protocols available where you can detect the malignancies in other subsequent family members early and treat them at an early stage. Ataxia telangiectasias, child with imbalance of the gait, and telangiectasias, they have more of TALS, and this is imperative not only to know from the therapeutic point of view or the prognostic, but also implications for transplant is also there. You might have to reduce your chemotherapy, radiotherapy should not be given. So it's important for us to know. There are a lot of conditions associated with familial ALL again. So our children were worked up for that. The first child had a Lee-Fromenick syndrome, the P53 mutation. The other members were also screened and counseled. This child, this family had a CMMRD, and this child had a familial monoallelic CPA AML. So whenever there should be a high index of suspicion in such classical syndromes, which we have all gone through to diagnose malignancy, should also be one of your differential diagnosis whenever you come across any other conditions, any one of these conditions. So thank you all for the patient listening.
Okay. Very interesting talk, Badra. I think Santosh sir is there, no? Santosh sir?
He's not there.
Okay.
Can you conclude the session?
Okay. I think, okay, Purushottam sir. Yes, Purushottam sir.
Thank you, Badra, Guru, Jitin, because this is a wonderful experience, learning experience. My second half, I am again going to be a student, learn mostly from all of you. And a few questions to Guru, Badra. And one thing is, what's your experience during this COVID period? Did they fare well? Any other complications during this COVID period in the pediatric malignancies? One question. Second is about the testicular painless involvement. Suppose there is a painful involvement superadded on that, there's a possibility of a torsion superadded on this thing. Is it considered as one of the emergencies? And another thing is a sudden loss of blindness. You said a lot of eye involvement is possible, out of which in the case of eye count, is there a possibility of the retinal artery block and sudden loss of blindness? Is there any leukoreduction or FRS is possible in such a situation? Can we save the vision is one. And one more thing is we had a few cases of element facial palsy as a part of Wingristin rather than the leukemic involvement. And about Guru, one question about the the cell release of the biochemical things, the catecholamine release is possible from the neuroblastoma and the pheochromocytoma-like situation. So is there a possibility of this producing hypertension or these things during, nowhere I heard about the this such a situation. That's also theoretically possible.
Solid tumors like neuroblastoma, especially neuroblastoma, not as sensitive to chemotherapy as ALL. So once you start your chemotherapy for tumors like neuroblastoma, like tumors which are in low risk for tumor lysis syndrome, those tumors which are of low risk for tumor lysis, the lysis rate is less. They start to lyse over a 2-week, 3-week period. So the mass also starts to decrease after around 10 days, 15 days only, the mass starts to decrease in size. So usually they don't produce tumor lysis syndrome. But the situation that you have told has been reported when surgery is going on. It has been reported with surgery, release of catecholamines and causing hypertensive crisis has been reported when surgery is going on. About COVID, sir, we do have taken all COVID precautions during that time with the help of peripheral pediatricians, as you also know. Many we have postponed many reviews. Some of the less intensive chemotherapies were taken from peripheral centers. I think your question is specifically to kids developing COVID during GANs. We do had COVID positive cases who were on treatment, but but fortunately many of them were not becoming sick. We didn't had any death that is directly related to COVID during this. Even though we had 3 kids who became very sick with MISC, parameters positive for MISC, but we didn't had any mortality. And those majority of them becoming COVID positive, in whom we have worked up for COVID, like COVID symptoms were there also, they didn't become sick. Only 3 became very sick, and maybe 4 or 5 needed steroids. Majority of others responded to supportive care.
So regarding sir's question, yeah, I will also try to answer that. It's a rare opportunity actually where you could actually answer, sir. Most of the time, sir will be answering our questions. So regarding COVID, I would like to say, so for us in our TMH, we had around 145, nearly 150 patients who were affected with COVID during the time. And our COVID-related mortality was around 4 to 4.5%. But this has to be taken with a pinch of salt. In a sense, our background mortality is very high because most of these people have been on therapy and are neutropenic, and they have had associated bacterial sepsis, multi-drug resistant sepsis, and other pneumonias, fungal pneumonias, and bacterial pneumonias. And on top of it, they had COVID. So this mortality, when we say COVID-19 related mortality is 4%, it has to be taken under the context of this high background mortality. Having said that, in these patients who were on active therapy, once the patient was afebrile, most of them have been stable. Once they have been afebrile and 1 week into the disease we have been able to deliver the scheduled chemotherapy in around 90% of these patients without much problem. So it was not a very difficult situation when compared to adult, the pediatric cancer patients who had COVID. But because we had given them chemotherapy, their delay in RT-PCR negativity was very high. Some of them took 2, 3, 4 months to clear their RT-PCR because we were giving chemotherapy even once they were stable. On top of
we actually stopped doing RT-PCR.
Yeah,
we only do antigen.
Yeah, we just
once they become positive,
yes,
we don't follow them with RT-PCR because many, as you told, many of them persisted to be RT-PCR.
So this has been a learning curve, the COVID period, because many of us, none of us have encountered such situations. So we have over the time adapted our policies, and now we are back to normal, back to all the things. And regarding other things, you said, sir, regarding retina. So retina involvement is not that very common. So this bleeding, this retinal visual difficulties due to leukostasis is more seen in chronic myeloid leukemias, the CML patients, rather than in AML patient, ALL, the acute leukemias per se, mostly seen in CML patients. And their cytoreduction, if they have impending, if they have these vision problems and impending retinal vision compromise, cytoreduction is imperative, and you can start cytarabine. Low-dose cytarabine can be given in such CML patients if the retinal involvement is causing problems. We give 100 mg per meter squared cytarabine. You can start on hydroxyurea, and other measures are also there for cytoreduction. So cytoreduction is a must in such patients. Regarding the element facial palsy, so it depends whether you had that element facial palsy at baseline or whether it developed during treatment. So usually the CNS involvement will be manifesting at baseline only. So they will have element facial palsy before any treatment is started. So mostly they would have had this, and they would have been prescribed steroids for herpes zoster, and they come to us like that. So that is when you have isolated element facial palsy. Now the VCR-induced facial palsy usually comes during treatment, and most of them are usually bilaterally symmetrical, but they can be an asymmetrical involvement also. And usually it is the ocular nerves which are they usually manifest as ptosis, bilateral ptosis, when coming to the cranial nerve palsies are concerned. You are isolated.
That is more common than facial.
Yes. And testicular involvement, as I said, it's pain in leukemia. It is painless, but if you have a super added epidermal erythema, it can be painful. And torsion is usually not seen in leukemic patients. First of all, the involvement is also less, and isolated testicular involvement to be manifested as a manifestation of leukemia upfront is not seen. Usually, they have cytopenias, which are the predominant manifestation, and they come to you at a point when the testis is also infiltrated simultaneously. So they usually don't go into torsion. And isolated involvement is usually seen at relapse. That also it is a diffuse involvement. They going into torsion is very rare in leukemic involvement. And as what is, I think that would clear your.
Yeah. Thank you.
Any more?
Thank you, both of you.
Yeah, that was a beautiful discussion. I think as time is running out, if no more questions, we can move to the next session.
Yeah, thank you, Chitan. Thank you.
Thank you.
Thank you, Guru and Badira.
Thank you, Purushothaman, sir.
Yeah, thank you, sir, for making this lively.
For
You
the
always
chance.
had made it very lively.
Now I welcome Dr. Johnny Sebastian, our State Secretary, to chair the next session. So kindly introduce the speakers and the topics.
A very good morning to all. Am I audible?
Yes, sir. Yes, sir.
At the outset, let me express my heartfelt gratitude to the organizers of this conference for inviting me to chair the session. Coming to the talk today, retinoblastoma is the most common intraocular tumor of childhood, mostly diagnosed between 1 year and 3 years. To enlighten us more on this topic, we have today with us an expert in this field, Dr. Fairuz, who again has roots here in Thalassery. She's a specialist in ophthalmic plastic surgery, orbit and ocular oncology from Bangalore. She is the founder director of Horus Specialty Eye Care, a one-stop specialty eye care in the field of eye plastic surgery and eye cancer. She is a recipient of AO Achievement Award in 2015 and APAO Achievement Award in 2017 for academic excellence. Also hold position as Scientific Chair for Asia Pacific Ocular Oncology Pathology Society. Her area of interest and research is retinoblastoma. With these few words, let me introduce our vibrant speaker, Dr. Fairuz. Over to you, madam.
Thank you very much, sir, for the kind introduction. Good morning, everyone, respected teachers, colleagues, and dear friends. I extend my sincere gratitude to the organizing team of Kerala PHOCON 2021 for this kind invitation. And I'm humbled and honored to be here in this platform where my favorite teachers are there. I'm very, very happy to see Dr. Purushothaman sir and Ananda Keshavan sir, who's here, and they are my teachers in pediatrics during my MBBS time. So happy to be here. And so I'm going to speak about my favorite topic here, retinoblastoma. I'm going to share my slide, and please tell me whether it is visible.
Yes, it is.
All right. Yeah. Dr. Jitin told me that I should be speaking on retinoblastoma pertaining to what the pediatrician should know. So I've put everything together, giving a brief overview of what is really, really important in the current scenario in the diagnosis and management of retinoblastoma. I have no financial disclosures or a financial interest, but I'm always thankful to the bunch of my patients and parents and mentors who have always made this, various researches in retinoblastoma possible, and the wonderful team that I work with, including pediatric oncologists, radiation oncologists, pathologists, geneticists, and the ocularist, and also team MCC. So I'm going to deal with a few cases here. I think it's easy to understand. So this was a child who the parents had sent the picture, who was earlier seen by various doctors. As you can see here, he has a red reflex in his right eye and a white reflex in the left eye. So this is, sorry. All right. Now this is his sibling. The parents sent another picture. Well, both the siblings were seen. So as you can see here, the younger sister of this patient also has white reflex in the eye. So what do you do when you see these patients? Of course, we all know the term called physiological leukocoria, when the eye is in a particular position and when the optic nerve is in focus, there can be a white reflex coming from the eye. But it is very, very important to rule it out. And just not think that it can be a leukocoria and ignore the situation and tell the parents, okay, it's okay to wait. It's not okay to wait. Now, let's see what happened to the elder brother. So this was what we saw in the younger sibling's eyes. And that was a physiological leukocoria. But when we examined the elder brother, he had a group D retinoblastoma in his left eye. So not all white reflex is physiological leukocoria. It's very, very important because there is a lack of awareness among the parents, among the public, and even among the doctors regarding this condition, where most of the things goes misdiagnosed and not diagnosed. So this child, the elder child, had to undergo enucleation, and this is how he landed up. This was a second case. This child was diagnosed to have conjunctivitis in the right eye. The child had, as you can see here, periocular swelling. The child had congestion in the eye, was seen by a pediatrician, was treated for conjunctivitis. But in fact, it started progressing. And then an MRI was advised. And as you can see here, this was a case of bilateral retinoblastoma presenting as a preseptal cellulitis due to the aseptic necrosis of the retinoblastoma, intraocular retinoblastoma. So retinoblastoma can present in various degrees and various clinical scenarios. This was a case which was diagnosed as a case of orbital cellulitis. Yes, it does have all the features of orbital cellulitis. As you can see here, there is periocular swelling, she has proptosis, and she was treated for orbital cellulitis for a very long time in the, in the hospital. And then since it was not resolving and it was progressing, an MRI was advised. And this was what we found in the MRI, where, you can see an intraocular tumor, which is growing outside the confines of the eyeball and extending into the orbit and the optic nerve. So orbital retinoblastoma can present as orbital cellulitis. So this was a case which was diagnosed as a case of cataract. Yes, congenital cataract can be present as a sole entity. And even retinoblastoma, if it is a large retinoblastoma which undergoes intraocular necrosis, it can lead to cataract. So this child did present as a cataract, but when an ultrasound B scan was done, you can see that there is a calcific lesion inside the eye sitting intraocular, almost sitting on top of the optic nerve head. So this was a case of retinoblastoma presenting as cataract. Retinoblastoma mimics. There are many differential diagnoses of a white reflex in retinoblastoma. So any white reflex, although there are many differential diagnoses, retinoblastoma should be kept first and always ruled out with detailed evaluation in these children. Strabismus is yet another presentation. So there are many incidences and many stories that come to us that the child had a small squint, they were seen by a doctor and then advised, well, once the child grows, the squint will go away, so it's okay to observe. It is not okay to observe until and unless you have done a dilated examination and peeped inside the eye to rule out any intraocular tumor. So why does the strabismus happen is most of the children who are born with retinoblastoma, the tumor will be sitting right at the fovea, and then it grows to occupy the entire macular area. So when the fovea and the macula is involved, what happens is that there is an amblyopia which is being developed. There is a visual deprivation amblyopia, and they will be squinting, mostly esotropia and sometimes exotropia in these children. So it's very important to rule out retinoblastoma when children presents with squint. So this is the case where, a tumor was hiding inside the eye with the patient with a squint. Buphtalmos. When children presents with this, hazy cornea, when the children presents with slight enlargement of, the cornea ipsilaterally, in the involved eye when compared to the other eye, that also mandates detailed evaluation and referral to an ophthalmologist. So as you can see here, retinoblastoma is, it's kind of a clinical spectrum. It starts as a small tumor. It can be in the posterior pole, it can be in the periphery, and then it enlarges to cause retinal detachment, which is quite visible externally. And then they can grow to, enlarged, to form an enlarged eyeball due to the large tumor inside the eye, leading to proptosis, orbital cellulitis, preseptal cellulitis, and very bad scenario of even extraocular extension and intracranial extension. The most important thing which we all should be aware of as pediatricians, because children first is seen by the pediatricians, you get the opportunity to see these children first and then come to the general ophthalmologist and then to the specialist. So there are various masquerades of retinoblastoma. It can present as a hypopyon, it can present even as a phthisis bulbi, redness in the eye, which can simulate a conjunctivitis, a subtle bleeding in the eye, where most of the time the parents would kind of relate to a trivial trauma that the child has gone, someone just hit on the eye and that is a, bleeding. They would attribute this to a trivial trauma, but it's very important to rule out intraocular malignancies in these children. So knowing the masquerades in retinoblastoma is very important. Retinoblastoma is a clinical diagnosis. The diagnosis of retinoblastoma is done by detailed dilated fundus evaluation, which includes 360-degree oral, the ora serrata examination as well, because they can be hiding tumors even in the periphery, especially in older children. So this is exactly how a retinoblastoma looks like, and this is a group B retinoblastoma. So these are the equipments and instruments that we as retinoblastoma specialists and ocular oncologists use in our regular practice. We use an indirect ophthalmoscope, we use a 20D lens, the speculum, a cotton buds, the intraocular pressures are checked, the ultrasonography is done right there under anesthesia, a good documentation. We draw everything, we measure the tumor, we see whether it's only the tumor or it's more than that, whether there is subretinal fluid, seeds, vitreous seeds, etc., and everything is documented. So all these examination is done under general anesthesia, and we do a documentation with our red cram fundus photography as well. And as far as the treatment, these are the favorites of the retinoblastoma specialists. We do the focal treatment with transpupillary thermotherapy. It's an infrared diode laser. Then cryotherapy is kind of a third hand of an ocular oncologist, be it any tumor and especially in retinoblastoma. So this is the same case. It was a bilateral retinoblastoma. One eye was advanced. It had to be enucleated. And this particular case, it's occupying the macula area. So vision salvage was very, very important in this child. This child underwent chemoreduction with systemic chemotherapy. And as you can see here, a fovea sparing laser therapy, transpupillary thermotherapy was done along with it to spare the fovea and the vision in this child with 6/6 vision. So going on to retinoblastoma management, the goals are very important. The primary goal is always life salvage because it's a cancer, it's a malignancy, and in advanced situation, they can be deadly. Eye salvage would be the secondary goal and vision salvage would be the tertiary goal. Chemotherapy in retinoblastoma has been a great success so far in the primary management. We have two kinds of chemotherapy. One is systemic chemotherapy and the newer introduction of targeted chemotherapy, that is intra-arterial chemotherapy. Both has pros and cons. In a developing country like India, intra-arterial chemotherapy is on the expensive side. It requires expertise. So most of the patients that I treat in retinoblastoma in India, I would say 97% of the patients, because most of them are from a financially, backward society, undergo systemic chemotherapy with equal benefit and equal, favorable outcome. So the adjuvant modalities that we use in retinoblastoma management would include cryotherapy, laser therapy, periocular chemotherapy, intravitreal chemotherapy, and plaque brachytherapy in various stages of treatment of tumor, along with chemoreduction, be it systemic chemotherapy or intra-arterial chemotherapy. So I'm going to show you a few outcomes of systemic chemotherapy in intraocular retinoblastoma. It's very, the outcome is extremely favorable in Group A, Group B, and Group C. As you can see here, the life is salvaged, the eye is salvaged, and the vision is also salvaged along with adjuvant therapies. Group D tumors, there are Group D tumors where you will be able to salvage. We do give, we do initiate chemotherapy in order to try to salvage the eye even in Group D tumors. But some severe Group D tumors, it often becomes difficult to salvage the eye. And Group E tumors are those where enucleation is preferable as a treatment of retinoblastoma. Now, I'm going to show you one interesting case over here where this child came with bilateral retinoblastoma. The left eye was having ophthalmos. He was even having a staphyloma where we had to enucleate in order to avoid any orbital extension and, mortality. So this is the only eye that is the right eye with Group D tumor. As you can see here, the whole eye is filled with the tumor. And these are the vitreous seeds, the vitreous clouds, and the optic nerve is not visible. Well, we did want to save this eye as badly as possible. So what we did was, the child was started on systemic chemotherapy, and this is post chemotherapy with almost regressed tumor over here. And this is post chemotherapy 6 with intravitreal topotecan injection, 2 of it, which was given, intraocularly in this child. And we were able to salvage the eye. We were also able to salvage the vision. As you can see here, the foveola is intact, and this child is seeing with his eye with systemic chemotherapy. Now, intra-arterial chemotherapy is a newer advent in the treatment modality of intraocular retinoblastoma. So it does take care of eye salvage. It does take care of vision salvage to a certain extent. But of course, life salvage with intra-arterial chemotherapy is not possible because it's targeted and the injection is directed towards the eye. And there is no systemic, chemotherapy which is being instilled in intra-arterial chemotherapy. So why has it caught a lot of attraction and why has it become so popular recently is that, so as you can see here, this is our series of cases that we have published. So on your left, you can see the success rate of chemoreduction as far as eye salvage is concerned. Excellent in A, B, and C. And well, D, as you can see here, with systemic chemotherapy, it is reported as 47%. But when we come to intra-arterial chemotherapy, you can see a jump to 94%. So intra-arterial chemotherapy is very effective in advanced intraocular retinoblastoma, especially in group D eyes. So what is intra-arterial chemotherapy? It's a direct intraocular delivery of chemotherapeutic agents via the ophthalmic artery. It of course increases the increased drug concentration and also minimal systemic absorption and minimal systemic complications. So the drugs used are melphalan, topotecan, and carboplatin. My favorite is topotecan, and it can be used as a single drug, it can be used as a double drug or a triple drug. And in my practice, I prefer a double drug, including melphalan and topotecan. I'm just going to show you a quick video over here, thanks to Johns Hopkins for this wonderful video that they introduced. So a catheter is introduced through the femoral artery, internal carotid artery, and then they come to the branch of ophthalmic artery over here. After ensuring that the catheter is right there inside the ophthalmic artery with fluoroscopy, then the chemotherapeutic agents are injected directly into the ophthalmic artery. As you can see here, there's a fluoroscopy confirmation, the drugs are injected, and it's directly, goes and affects and chemo reduces the tumor. So this is how intra-arterial chemotherapy works. Now, is it effective? It's very effective. So this is a group D tumor with intraocular retinoblastoma. And as you can see here, these are 3 sessions of intra-arterial chemotherapy. You can see the entire tumor has regressed. So everything comes with, trade-offs. So as far as intra-arterial chemotherapy is considered, it's very, very important to know that there are vision-threatening intraocular complications that can be associated with it, including choroidal atrophy, vascular thrombosis, central artery occlusion, etc. So whenever there is a situation where you actually want to salvage the vision in a child, in a bilateral retinoblastoma, you should always think twice or thrice whether you chose intra-arterial chemotherapy. So indications of intra-arterial chemotherapy is absolutely outlined, and we follow those protocols. So the common side effects are hyperemia, eyelid edema, and we even see alopecia in that side of ipsilateral side of intra-arterial chemotherapy, which are transient and not too disturbing for the patient. Next is intravitreal chemotherapy, which is again a recent introduction in the treatment of retinoblastoma. Although it's not a primary treatment, it is a secondary treatment after chemoreduction, and this helps in treating intravitreal seed, subretinal seed, and to a certain extent small endophytic tumors. And the chemotherapy drugs used are melphalan and topotecan, and my favorite is topotecan due to relative, less toxicity to the retina. And this is exactly how we do with a 32 gauge needle, past planar approach, 3 millimeters minimum at 3 clock hours away from the tumor deposit, and it's directly introduced into the eye. Now, this was a child. He presented to me at 13 years of age. And this is bilateral retinoblastoma, one eye enucleated, as you can see here. The other eye underwent systemic chemotherapy, even underwent radiotherapy, when he was 3 years of age, many, many years back. At 13 years of age, 9 years after completion of treatment, he came with recurrence. And this is how his eye was looking like. He had lots of vitreous seeds. These are spherules of vitreous seeds sitting in the eye. There was a tumor recurrence, as you can see here, and this tumor was the one which was spitting these vitreous seeds into the eye. So we thought about options, whether to continue, restart the systemic chemotherapy for him. Parents says he had allergy to systemic chemotherapy, and that's why radiotherapy was opted as a primary management for him. Well, the only thing that I did was to inject intravitreal topotecan into his eye, and this is how the entire vitreous cleared off without even systemic chemotherapy, with vitreous recurrence in this child, and the eye was saved. So this particular paper was presented at the International Society of Ocular Oncology in 2019 at Los Angeles, and this is our results of intravitreal topotecan in retinoblastoma with good regression, 100% regression in these children, and recurrence. There was vitreous recurrence, but associated with tumor recurrence in one of the child. Now, as far as developing country is concerned, we have to accept the sad fact that the prognosis of retinoblastoma is poor. The reasons are late detection, advanced disease, and well, we have seen enucleation rate of 40 to 80%, although it has come down drastically recently with the introduction of newer modalities. Now, we have also seen that 20 to 30% of children die despite primary enucleation, and one, it's due to improper technique, and also the lack of identifying the pathological risk factors for systemic metastasis. It's very, very important not to just enucleate the eye, but thorough evaluation of the eyes by the pathologist, specifically looking for the histopathological risk factors, is very, very important in further management of these children. So when we do enucleation as an ocular oncologist and retinoblastoma specialist, we make sure that the optic nerve stump is pretty long, because if at all there comes a transection positivity in a child with retinoblastoma, although you have done enucleation, and if you give chemotherapy, it's going to be a very poor prognosis. So we take care of all these things, even the minute details. Now, these are the list of pathological risk factors. I'm not going into the details, which can have, risk of systemic metastasis, and they will need further metastatic evaluation and adjuvant chemotherapy. In the presence of optic nerve invasion to the level of transection, scleral invasion and extrascleral extension, and addition of orbital EBRT is also added. Now, the last portion, I'm just coming to the last few slides of my talk, orbital retinoblastoma. It is the biggest red flag in the management of retinoblastoma. And there is, as the tumor advances in the orbit, in the optic nerve, and into the cavernous sinus and intracranial, the prognosis becomes as poor. But with the recent introduction, thanks to my mentor, Dr. Santosh Honavar, and he introduced this treatment protocol, and we all follow this as retinoblastoma specialists, the intensive multimodal treatment protocol, where high-dose chemotherapy is administered, followed by enucleation after radiological confirmation of regression of the orbital component and the optic nerve component of the tumor, followed by external beam radiotherapy, as planned, with the primary presentation of the orbital retinoblastoma and completion of high dose of chemotherapy, 12 cycles. And the universal protocol of VEC is followed over here with an escalated dose. So this was a child who presented with an orbital retinoblastoma, a tumor sitting in the inferior and medial portion of lateral and medial portion of the orbit. She underwent the intensive treatment protocol. So before that, I'm just going to take you to some data over here. So with the conventional treatment of exenteration, just chemotherapy, radiotherapy, the prognosis of survival has been dismal. But with this, in our study, we evaluated 40 patients, and we found that with multimodal treatment protocol, the survival has been again favorable to 90%. Now, before I finish my talk over here, one of the most important thing that we all as ophthalmologists, as pediatricians, as specialists should be aware of is this particular scenario over here. So this father walked in with this child. As you can see here, there is white reflex in the left eye and right eye looks okay. So he looks very stylish over here. Now, the unfortunate situation that we all forget is this father had bilateral retinoblastoma. In those times, it was treated with enucleation and radiation, and this is how he looks like. But we couldn't avoid the situation with this, what baby presented, where the father was absolutely not aware that retinoblastoma is a genetic disorder. No one is ever told that when his child is born, the first thing that he needs to do is to evaluate the eyes of the baby. And he was not aware of the fact. And the baby presented with bilateral retinoblastoma. In fact, the left eye was so advanced, it had to be enucleated. So again, the genetic predisposition and the awareness, which has to be, that we have to inculcate among us and spread among the patients and make them aware of the fact that it is a genetic disorder and it need to be tackled, has to be given prime importance. And we do have genetic test, which is available in most of the institutes for, knowing whether it's germline or somatic mutation retinoblastoma. So I conclude over here. I hope I could give a brief overview in the limited time, covering everything. And first and foremost, retinoblastoma is just not treated by a retinoblastoma specialist or an ocular oncologist. It involves a team of specialists, and the specialist starts from pediatricians, where the babies are seen primarily and initially ophthalmologist, ocular oncologist, pediatric oncologist, radiation oncologist, pathologist, and thanks to all the team members who have been working with me, including Jitin and the MCC team, for doing a great job in the treatment of these patients. So, the message is very clear. Management goals are very clear. Systemic chemotherapy is affordable and effective. Arterial chemotherapy, yes, it has a very major role in the treatment of retinoblastoma, especially in the advanced intraocular varieties in the group D, but it has to be used with caution, knowing the vision-threatening complications. And genetics is very, very important. And I hope in future we all apply genetics to clinical application. Thank you so much, and long live our champions. Thank you so much.
Thank you, madam.
Thank you. Thank you, Dr. Fairuz. Thank you for that excellent and lucid talk covering all the topics, especially about the emphasis on the genetic predisposition. As you know that if a parent with bilateral retinoblastoma, almost 45% chances are there for the offspring to have it.
Yes.
So we need to be very careful about that aspect also. Thank you so much. And since we don't have any more questions in the chat box, I feel we'll move on to the next topic. Our next topic is saving from febrile neutropenia. As you all know, febrile neutropenia can be a life-threatening condition, as these children have an impaired ability to fight infections. And hence, these children should undergo an initial risk assessment at the earliest. To throw more light on this subject, we have our dynamic secretary and an expert in this field, Dr. K.G. Gopakumar. He's a busy pediatric oncologist at Malabar Cancer Center, Thalassery. He did his MBBS from Government Medical College, Calicut, MD from KMC Mangalore, and DM from the prestigious Regional Cancer Center, Trivandrum. His areas of interest are childhood leukemias and supportive care in oncology. Over to you, sir. Dr. Gopakumar?
Yes, thank you, sir. Hope I am audible.
Yeah, you are audible.
Okay. Respected senior members in the platform, teachers, my dear colleagues, and dear friends. Let me at this onset, first of all, thank the organizing team for providing me with this opportunity. Okay. Excuse me. So at this onset, when Jitin gave me the topic for discussion in the conference, he did not mention whom to save from febrile neutropenia. So by the end of this talk, I hope I'll be able to save the child definitely. Whether I'll be able to save the doctor treating the patient, or both of them I can be able to save, I'm not sure. I hope through this talk you will be going through the common definitions of febrile neutropenia and the general principles in the management of febrile neutropenia, and what the guidelines tell, actually, what evidence do we have to make some recommendations. And basically, I'll be talking about a practical approach, how to deal with febrile neutropenia. So till some time back, we only had adult guidelines for management of febrile neutropenia. Different societies and organizations like the ASCO, IDSA, ESMO, European guidelines, NCCN had come up previously with guidelines for management of febrile neutropenia in adults. But literature on management of febrile neutropenia in children were very few. And it was only in 2012 recently that the International Pediatric Fever and Neutropenia Guideline Panel was formed with experts from more than 10 countries. And they actually and discussed about how to risk stratify these patients and how to go about the evaluation and how to manage these patients. And the guidelines were published in JCO in 2012. And basically, before going to the guidelines, some of the definitions. As the name suggests, febrile neutropenia is having a fever and a neutropenia. I hope all of you might be knowing how to calculate the absolute neutrophil count based on which neutropenia is defined. So basically, if a total count is 1,000 and you have a 25% neutrophil, the ANC would be around 250. And by definitions per se, fever is defined in textbooks as a single oral temperature of 101 degree Fahrenheit or 100.4 degree Fahrenheit sustained over a 1 hour period. But in this part of the world and many places, we are not checking the oral temperature in routine. So in accelerated temperature, if you see a single recording of 100 degree Fahrenheit or more than 99.4 degree Fahrenheit sustained over a 1 hour period, we call it fever. And what is neutropenia? Neutropenia, in the context of definition for a febrile neutropenia, ANC less than 500 is taken as a neutropenia. But generally, if you ask what is neutropenia, as Ajit Kumar and other speakers told before, neutropenia is anything ANC below 1,500. But in the context of a febrile neutropenia, definitions consider ANC of less than 500. This is because complications are more if ANC is less than 500. So a neutropenia is any ANC less than 500 or an ANC which is expected to decrease to less than 500 in the next 48 hours. And profound neutropenia is ANC less than 100, and a prolonged neutropenia is a neutropenia persisting more than 7 days. So why should we worry about this febrile neutropenia? Just seen that mortality of an untreated febrile neutropenia ranges anywhere from 2 to 21%. And recently the mortality rates are increasing because of the emergence of multi-drug resistant organisms. So before going to the evaluation of a patient with febrile neutropenia, let me remember you this, like febrile neutropenia is a potential medical emergency and we should not be at a slower pace. We should run for treating the patient. And as you know, many chemotherapy patients will be on chemotherapy, and due to this, there is a decreased inflammatory response, and whatever localizing signs you may get in a normal child may be blunted or absent. And fever is also not a must because of all these decreased inflammatory response that is happening in the body. And never neglect subtle signs and symptoms which the mother tells. Like if the mother tells the child is having a problem, take it for granted the child is having some problem, and you assess the child properly. And as in any other situation, evaluation goes with the history, physical examination, and then investigations and diagnostics. And taking history, when you hear the call from the emergency department that a child on treatment with cancer has come, don't get baffled. If the situation is manageable anywhere, you just have to get a detailed medical history from the patient or the mother or the relatives who has come with the child, and you ask them many of the patients will be able to tell what the child is having, which type of cancer the child is having, and what phase of chemotherapy they are in. And you can ask for any recent surgeries. And the important thing is you review the medical records, whatever is there with the patients. Most of them come with the reports, and see if any previous culture reports are also available with them. This will actually help in tailoring your treatment. So the type and duration of recent chemotherapy has to be seen, and any patient who has had a chemotherapy in the past week is at risk of febrile neutropenia. You ask for symptoms of different systems and to get a focus of infection. So, and this next suggestion, like as you can ask also the patients or bystanders, like ask for the phone number of a treating oncologist also. This will actually help in communicating with the treating oncologist, and he may have his own inputs to give you while managing this patient. So that is also, if you can get, it is good. And the idea of a clinical examination is the early identification of patients who are going for complications. Like you pick them early, the better. So the children may present with mild symptoms or maybe totally asymptomatic, or they can present in the other end of the spectrum where you can have a severe sepsis or MODS type of presentation. Like initial presentation might be with a mild fever, chest pain or tiredness or cough, or some pyoderma, some abdominal pain or vague abdominal pain or loose stools. But later, sometimes because of late detection and late presentations, some of them may end up presenting with a hemodynamic instability, respiratory distress, hypoxia, or an altered mental status. The idea of treating or managing febrile neutropenia is to pick up the patients early and to delay the complications or avoid complications. So as I told before, the cardinal signs of inflammation are absent, will be absent or dull. So you don't expect major signs or symptoms maybe. And in physical examination, what to look for? So the first and the most important thing is you go and see the patient, and never treat a febrile neutropenia patient over phone or by like telemedicine or something like that. It's always better to go and see the patient and assess for yourself what is happening to the child. So you assess the general condition of the child, you look for any focus of infection, and where to look for infection. Wherever there is a hole, you look for infection, like a focus. You see the oropharynx, you see the respiratory tract. The perianal area is one of the most neglected areas while examination because of many issues. But definitely in a child, you see for the perianal area because patient may not be having any symptoms, but there may be a bulging perianal area with the abscess or something, which is likely to be missed. So definitely you have to assess the perianal area, which is a focus of infection. Most of the patients will be on central venous catheters. So you assess the central venous catheter sites and any recent invasive procedures done, you see what is happening to that area, as well as skin and soft tissues, swellings, you can see. You basically assess the child from head to toe. So after assessment, you make a general assessment of the patient. You see, if the patient is not stable, you make every measures to stabilize the child, and you plan investigations. So what baseline investigations you can be doing is like a hemogram or CBC, and to see the many patients on chemotherapy will be having some altered renal or liver function test, or as a part of sepsis also they might be having some alterations. So you can do an RFT, LFT, and sugar levels. Urine routine actually in pediatric oncology practice has not much role in because of the blunted inflammatory response, you may not get enough puzzles to document any or suggest any infection. The ideal thing is to go for a urine culture. So serum biomarkers, whether there is any role, there are still controversies and emerging evidence, but CRP and procalcitonin. But actually at present, there are no much recommendations as to do whether there is any need to do it at the initial period. What we have seen is like you can get some idea if you do a CRP at the onset, and then later if the CRP is increasing or decreasing trend, you can have a rough idea about what you're going through. But there are actually no recommendations as such whether there is required during management of febrile neutropenia. So the ideal thing and the most important and the first thing to do is to get a culture. You develop a culture of getting cultures done, and what cultures, both blood and urine cultures are recommended. And what the recommendations tell is like blood cultures, you concomitantly get cultures from both the peripheral line as well as the central line. All the lumens of central line, you should get separate cultures. And this is helpful in differentiating catheter-related bloodstream infections from proper sepsis. And sometimes you might have a chance to salvage the central line. So any other cultures should be based on clinical suspicions. If the patient is having cough and sputum, you can get a sputum culture done. Any swabs can be taken from any inflamed or discharging sinuses or mucous membranes, you can get it. And ideally, what they recommend is before starting antibiotics, try to get the blood cultures done. And mind you, don't wait for the patient to give you the urine sample or the sputum before starting antibiotics, because that may get delayed, and there is also no need. Once the blood cultures are taken, you start antibiotics initially. So other investigations, what we tend to do is a chest X-ray. So what is the role of chest X-ray? In asymptomatic patients, it has been seen that very less patients, less than 5%, have the probability of getting a positive chest X-ray. So in asymptomatic patients, there is no need to take a chest X-ray. In symptomatic patients, well, yes, that has a definite role of chest X-ray, and pulmonary infiltrates are often got, and it will actually have make you aware of the situation. And if you want to add any additional coverage for communicated pneumonia or antifungals, can be done, but this should be guided by additional diagnostic testing like a CT thorax and a bronchoscopy. So if the patient has a persistent respiratory symptoms and a normal chest X-ray also, CT thorax is warranted, because everything might not be picked up in a chest X-ray. And regarding ultrasound, if symptomatic, the patient is symptomatic with loose stools or abdominal pain, definitely you can go ahead with an ultrasound examination. Even in asymptomatic patients, if the patient is febrile for more than 72 hours, and you can do an ultrasound abdomen, well and good, to see for any fungal involvement of the kidneys or the liver. So once you have done your investigations, the proper way to go about, you risk stratify the patient. Like the risk assessment, the risk assessment data usually comes from the adult management guidelines for febrile neutropenia. Why this risk assessment was put into practice or is coming into practice is like, it was seen that all the patients, the previous view was that all the patients who are having febrile neutropenia require admission and was started on antibiotics and IV antibiotics. But later it was shown that no, it was understood that from previous studies and practice that not all patients require admissions, and some of the patients can be managed as OPD with oral antibiotics. So this is the multinational association of this in cancer scoring. It is usually supportive care in cancer scoring system. This is usually used in adult population based on multiple parameters. And there are 5 to 6 pediatric risk stratification scoring systems available. These are all small studies, and none of them are actually contributory. Like a general recommendation could not be made from any of these studies so as how to go about in risk stratifying patients with febrile neutropenia. So based on many parameters, risk assessment is done to stratify patients into low-risk patients and high-risk patients. Low-risk patients can be treated in OPD basis, and high-risk patients require admission and IV antibiotics. So how to risk stratify these patients? There are many ways which you can assess the many things you have to assess. One is the general condition of the patient and the underlying malignancy, what type of malignancy the child is having, this aggressive hematological malignancy, type and intensity of chemotherapy, medical comorbidities which may affect the renal and hepatic impairment, and severity and anticipated duration of neutropenia or any other localizing symptoms. So based on this, a patient can be classified into a low-risk patient for complications if the ANC is less than 500 and expected to resolve within 7 days, mainly in solid tumors or in acute leukemia, ALL maintenance therapy, without any comorbidities with adequate hepatic and renal function and no other high-risk criteria. So all these patients can be categorized into a low-risk group. And the high-risk group includes patients in which neutropenia is anticipated for more than 1 week, like patients on intensive chemotherapy, acute myeloid leukemia, Burkitt lymphoma, or induction phase of acute leukemia, acute lymphoblastic leukemia, or a relapse salvage chemotherapy. And if any patient comes with the ANC of less than 100, has a poor general condition, hypotension, hypoxia, tachypnea, new changes on an X-ray, altered mental status, severe mucositis, and any focus of infection somewhere which you can document, and a poor nutritional status, all these group goes into high-risk patients. So you never send this patient on oral antibiotics, you admit them and give IV antibiotics. So remember, for a low-risk group, you based on these parameters, you assess the condition of the child and you categorize them into a low-risk group and a high-risk group. A low-risk group can be treated as an OPD patient with oral antibiotics. High-risk group requires admission and IV antibiotic care. One important point to note is that patients on low risk, even though the recommendation is you start antibiotics and manage in OPD, definitely call them back at least within a 48-hour period and ensure follow-up so that a count can be repeated or a reassessment can be done. It is not that all low-risk patients does not get into complications. So you have to reassess the patient properly, regularly, and ensure that the patient is stable. So what antibiotics to start? So this is an article published in 2008 that has shown the pattern of pattern of organisms isolated from cultures. Here you can see that in the 1950s, gram-positive organisms were commonly seen, and there is actually a wave-like pattern, like fluctuating pattern, where gram-negative and gram-positive growth is organisms are isolated. And in the after the in the 21st century, there are more chance of invasive fungal invasions, fungal infections are also coming into picture. So what empirical antibiotics, IV antibiotics should be started in a patient with high-risk febrile neutropenia? Whatever in our setting we are suspecting is a gram-negative sepsis, and definitely as the picture goes, the previous picture has shown both gram-negative and gram-positive organisms are commonly seen. And the initiation of empirical antibiotic use actually started in 1970s And it has shown that the mortality has drastically decreased from 80% to nearly less than 40% with this strategy of starting empirical antibiotics. So what is the ideal antibiotic to be chosen? The antibiotic should have a broad spectrum antibiotic activity. Bactericidal, it should be bactericidal in the absence of any neutrophils, because all the children with chemotherapy, you do not expect any help from the immunity from the body, and should have a low potential for adverse effects. So in the low risk group, what the recommendations tell is that you start with an amoxicillin clavulanate plus ciprofloxacin, which will cover both gram-positive and gram-negative organisms. There are no other studies actually. In adults, there are studies of using levofloxacin monotherapy for treatment of low-risk febrile neutropenia. But in pediatric population, there is no recommendation for or studies with other drugs other than amoxicillin clavulanate and ciprofloxacin. So in a low-risk group, once you take the cultures and other things, you start on antibiotics, oral antibiotics with amoxicillin clavulanate and ciprofloxacin. And in the high-risk group, what the recommendation was going is like previously what was being taught was like a combined therapy was advocated. Like you start with the ceftazidime or amikacin combination. What was the idea was that when you use drugs in combination, there is an expanded antibacterial spectrum, and there is a potential synergistic interaction that will enhance the efficacy and lower the effective MIC of each component, and also prevent the emergence of infection. So, but with the advent of new carbapenems and third and fourth generation cephalosporins, the guidelines have changed, and now the recommendation is to use a single agent like monotherapy with a high anti-pseudomonal agent like piperacillin, tazobactam, or imiropinum. The recent update of this pediatric guidelines came in 2017, and in that they are also recommending cefepime also as a first agent which can be started. So the role of a combined therapy is now gone. Now what the guidelines and what you should practice is you should start any patient, high-risk patient with febrile neutropenia with IV antibiotic, which is piperacillin, tazobactam, or imiropinum, or cefepime. And so what antibiotics, you might ask what antibiotic I should start in my institute. So all these empirical regimens must be ultimately be individualized for each institutions. So you should see the culture patterns in your own institution and select the antibiotic. Most institutions prefer to start with a piperacillin, tazobactam, and then grade up the antibiotics later. So, but whatever antibiotic you choose among these, just make sure that you give the first dose as early as possible. That is in the golden hour. And as soon as you take the cultures, you give the first shot of antibiotic. Because many studies have shown, both in pediatrics as well as in pediatric oncology practice, that the timing of antibiotics has actually a crucial role to play in salvaging patients with febrile neutropenia. As early as possible, deliver the first shot of antibiotic. And when to add a second antibiotic, like even if the patient is having an ongoing fever, but the patient is clinically stable, there is no worsening of symptoms or no new symptoms, and there is actually no role of a second antibiotic which has been recommended. But yes, if there are new symptoms or symptom worsening, you can add on a second antibiotic later after 24 or 48 hours based on either your culture reports or empirically an aminoglycoside can be recommended. So is there a role for adding vancomycin initially? Actually, there are some situations where you need to be aware that vancomycin should also be added in the initial setting itself. Maybe a patient with skin or soft tissue infections around the catheter infection site, any critically ill patients who present with septic shock, pneumonia, or hypoxia, and any prior history of MRSA infection, and in healthcare settings with high prevalence of MRSA sepsis, and in patients with severe mucositis who is not looking well, there is recommendation that you can add vancomycin initially itself along with piperacillin, tazobactam. And how long to continue vancomycin should be decided on the culture reports. If the initial culture reports are negative for a gram-positive, okay, you can stop vancomycin well ahead, and that should be guided by the culture reports. So what is the role of antifungals and fungal infections in febrile neutropenia? As you all know, the diagnosis of fungal infection is a bit difficult, and studies have shown that withholding antifungal therapy has actually led to worsening of febrile neutropenia of the patients, and the outcome actually improved by early institution of therapy. So in any patient who has a persistent fever and neutropenia and on antibiotic for 4 to 5 days, the recommendation tell that you initiate an antifungal therapy. And because 1/3 of these develop invasive fungal infections subsequently. So if the patient is having febrile neutropenia and persistent fever on antibiotics for 4 to 5 days, you can initiate an antifungal therapy. Then somehow there are situations when you deal with febrile non-neutropenic patients. So in such situations, what to do? You can either observe with no antibiotics if the patient is not having an indwelling central venous catheter. Please underscore the statement. If the patient is having an indwelling central venous catheter line, even if the patient is non-neutropenic, you have to start antibiotics, because you don't know, like any patient, it is a focus of site of infection. So unless you take a blood culture and see whether it is harboring any organisms, we are not sure what is the situation. So if there is an indwelling catheter and the patient is having fever, you take cultures, and even if the patient is non-neutropenic, you start on empirical antibiotics. So how long to continue this antibiotic therapy? So when to stop antibiotics? So once the patient has counts have recovered well, ANC has improved, the general condition has improved, there is no new focus of infection, and patient has been febrile for more than 48 hours, blood cultures has become sterile, and you can stop antibiotics. As told earlier, you stop vancomycin early if the culture is negative for a gram-positive cocci. So in other situations about other antibiotics, you assess the patient and you stop antibiotics only such situation happens. So the other question that we commonly see is like, are there any role for any colony stimulating factors like granulocyte colony stimulating factors like filgrastim, pegylated filgrastins, etc. Regarding use of colony stimulating factors, there is something called a primary prophylaxis. Primary prophylaxis is done in an attempt to decrease the myelosuppression after chemotherapy. So there are situations when chemotherapy is intensive chemotherapy is given, patients are given colony stimulating factors after 24 hours of chemotherapy. That is called primary prophylaxis. This is an attempt to decrease the myelosuppression. There is something called a secondary prophylaxis. This is an attempt to prevent a recurrence of a febrile neutropenia or any delay in subsequent chemotherapy administration. So this is called a secondary prophylaxis. And sometimes patient we see during treatment of an established neutropenia to prevent an infection, sometimes GCSF or colony stimulating factors are used. And some of them use left and right for treatment of an established infection if it is associated with febrile neutropenia. But what recommendations tell is, or what evidence we have is for GCSF use only as a primary prophylaxis. It has been seen that it reduces the risk of febrile neutropenia. It reduces the chemotherapy dose reductions or any delays in subsequent cycles. It reduces the antibiotic use for febrile neutropenia related infections, and it is also reduces acute FN related hospitalizations. Other than this, routine use of GCSF in febrile neutropenia patients are also not recommended by any guidelines. If you search the articles on febrile neutropenia recommendation in the PDF, if you search a word type C, like colony stimulating factors, you will not be able to see any word at all. So, but some of the common practice is emerging, like you can consider GCSF in high risk of, if the patient is having high risk of infection or severe infections or infections unresponsive to antibiotics. But these are all emerging evidence, but none of the, at present, we don't have any recommendations as such from large bodies of evidence. To summarize, febrile neutropenia, as I told, is a medical emergency, and low risk FN is manageable at peripheral centers. And timing of first dose of antibiotic is the most crucial thing. And you give the antibiotic as early as possible, and you'll be saving a life. And you should all develop a good culture of taking cultures, and definitely you should get a blood culture done and a urine culture. Other cultures, if it is possible, we all know how difficult it is to get a urine culture or a expectorated sputum. So don't wait for that. You take cultures whatever is possible and start your antibiotic first dose as early as possible. And early referral to a dedicated center with the facility to manage complications is also a thing which has to be kept in mind. And I know this audience, we have doctors working in the periphery, we have the PG postgraduate students and many other mixed audience. So what I can share is like all febrile low risk febrile neutropenia patients can be managed at peripheral hospitals and clinics, but you have to make sure that a close follow-up is kept in these patients to see for any worsening or other problems. And any high-risk febrile neutropenia patients, and in your facility, if you do not have any ICU facility or infrastructure to take care of the complications which can happen in such patients, even if you have started treatment early, we don't know what can happen. But if you don't have any facility for managing such critically ill patients, the patient needs referral. You give the first dose of antibiotic, stabilize the patient and supportive care. You refer the patient to a center which has the facility to deal with such situations. And for high-risk febrile neutropenia patient with an ICU facility, you can well manage the following, manage the patient with following the guidelines, and you can always contact the treating oncologist for inputs. So what, on my perspective, a good interpersonal communication and rapport between the peripheral hospitals and treating cancer tertiary centers are the key actually to deal with the decreasing morbidity and mortality of any febrile neutropenia. So thank you.
Thank you, Dr. Gopakumar, for that detailed and clear presentation. In fact, it was just like leaving no stone unturned on your way. Purushothaman sir, would you like to add a few points? Purushothaman sir, unmute.
All the topics are all excellent. My request to both Guru and Dr. Johnny, hereafter we should be arranging more and more of decentralization of pediatric malignancy management. And there again, we should take it as a, we should take messages from all these experts. One thing from Faru's talk is there should be pediatricians, peripheral pediatricians should be aware of the malignancies which are likely to present in a silent manner like retinoblastoma, and annual at least ophthalmologist evaluation of recent squint, other visual problems and other markers of the retinoblastoma is to be done. Otherwise, it may advance to the higher levels. So annual monitoring of malignancies, especially those which are likely to be missed by the casual examination. Another thing, Gogumar talk, the pediatricians monitoring the malignancies in the periphery should know how to detect the sick febrile neutropenias, and maybe if the referral is taking time, give the first dose of antibiotics. And it need not be, you may be compromising the culture, you may not be giving the ideal antibiotic, but the timing and the choice of the antibiotics and giving it the right time, whatever antibiotics, maybe in the periphery, ceftriaxone or aminoglycosides or what, maybe the available things, vancomycin, the higher end antibiotic may not be available, and you may be compromising the ideal culture situation, but that saves.
That
so
is very important, sir.
These are the messages to be conveyed even after this oncology, CMA and all, that should go out with a message to the pediatrician. That should be a lot of practical things which even the pediatricians from the periphery should learn. My doubt to Virus is about the intra-arterial chemotherapy you said to the ophthalmic artery. Unlike a systemic drug, we are exposing the entire part to the drug, but it's a higher concentration you are delivering. You intend to deliver it to the tumor only, but you're exposing a little higher dose to the rest of the retina also. Will that produce any little adverse problems in the visual macular involvement or?
Yes, sir. So I did show that chart of complications. So melphalan carboplatin is more toxic drugs to the retina, the choroid, than topotecan. It does have its side effects. So initially, the side effects were more common due to the blockage of these small vessels due to the particles. Now we are very, very, cautious in filtering these drugs before they are injected in order to prevent occlusions. So yes, it is associated with toxicities. So I also mentioned in my presentation, so when it is a scenario where I want to salvage the vision in a child, in a better eye, in a bilateral retinoblastoma, I would never prefer intraarterial chemotherapy. I wouldn't take that risk.
One more thing is there any protocol for the monitoring of the siblings and the other siblings every year follow up, or any genetic marker detection or anything? Any protocol for that?
Yes, sir. We do have very strict protocols for sibling screening in retinoblastoma. So the sibling screening, well, if there is a genetic test which is available, which is not affordable for most of the patients in India. So we do see these patients whose genetic test is not available, like immediately after the birth, then it's every 3 months for the first 1 year and every 6 months for the next 2 years. So if it is a germline mutation, retinoblastoma will happen before 3 years of age. Now, if the genetic markers are available and if it is not a germline mutation and it is a somatic mutation, the chances are very, very less. So there is definitely an initial evaluation of the baby when the baby is born. Then it is a 6 monthly follow-up for the next 1 year.
Thank you.
Thank you, sir.
Thank you,
also like to
Purushottam sir,
join
and Dr.
Purushottam sir.
Fairuz.
Thank you very much.
And there's one question in the chat box for Dr. Gopakumar. If we have given MOXCLAV course for a non-severe febrile neutropenia, next time if the child presents, what will you give?
Like every febrile neutropenia episode has to be taken as the first episode. Like you have to assess the patient each time the patient comes with a febrile neutropenia episode. That is the most important thing. Then only you have to stratify the patient properly with all these parameters and assessing the child. And again, the patient is having a low risk for febrile neutropenia. The recommended antibiotic is amoxicillin with ciprofloxacin only.
Okay, thank you. So we can again repeat that moxiclav with plus ciprofloxacin. Thank you.
But the definitive thing what you have to keep in mind is you have to have the follow-up of the patient. You would never lose hold of the patient. You ask them to come back within at least 24 or 48 hours and have a reassessment done. Sometimes the patient might require, next time when the patient comes, the patient might require an IAP care.
Thank you, Dr. Gopakumar. We had a very catchy sentence from the talk that we should all develop culture of doing blood cultures. That's very important.
That I would like to join Purushottam sir in one point. You should develop the habit of culture, but culture should not wait the first dose of antibiotic. If you're working in a center where you are not able to send the culture, don't wait for waiting culture to give the first dose of antibiotic. It does not matter. The first dose of antibiotic is more important than getting the culture. Like if you're in a center where you cannot access an IV line, if the platelets are okay, you can use Ceprax on IM and then only refer to a center where further management is going to happen. And to join one more point that Purushottam sir was telling, we pediatricians are at a very unique position where you happen to see children less than 3 years who are otherwise normal 3 to 4 times. Those are your well baby clinics, your immunization clinics. Those are in place where you can detect early malignancies. Like every time you see a patient for immunization, please throw a torch in their eyes to see whether both eyes, if there is a leukocoria or if there is loss of that red reflex. During every immunization visit, you have a immunization visit at 45 days, 2 months, 1.5 months, 2.5 months, 3.5 months, 9 months, and 1.5 years of age. And this is a typical age where retinoblastoma presents. So probably during every well baby clinic, your examination should include throwing light to the eyes of the babies and just palpate the abdomen also. you will be finding an asymptomatic Wilms tumor or an asymptomatic neuroblastoma, or sometimes a retroperitoneal rhabdomyosarcoma. Things like that can be detected even before parents comes to you with a asymptomatic abdominal mass. So during your well baby clinic, throw a light into the eyes, palpate the abdomen during every visit.
Thank you so much, Dr. Guru Prasad, for highlighting that. Thank you so much.
Guru,
No,
Guru, Johnny, may I add one just comment for the pediatricians for IAP to take up? Guru, Anandakeshwan is there, and Jairam. All of you should take up messages from all these CMAs. Previously, a few months back, I heard about the CDH also. The role of the first visit, follow-up visits or immunization visit, we should be incorporating few of the early detection things, like one thing which Guru said now, looking for the reflex eye. The second thing is not to miss the CDH, and this can be taught to the ASHA workers and Anganwadi workers also.
Yes.
So our hereafter we should be moving out of the RCC and higher level centers, and we should be moving more and more to the periphery, and the workers, grassroots workers also can contribute to the early diagnosis and management of the many of the issues. When you talk about the malignancy oncology, we'll talk about only that. But there are a lot of other things which we can empower the grass level root workers by training them, making them also aware. So maybe they'll be going to, they are more interested, be more connected with these level people. So they also should be taken into consideration.
So as we had a talk on this before with you, sir, we are actually framing a network, and it will be outsourced.
Thank you, Dr. Guru Prasad, Dr. Purushothaman, Dr. Fairuz. As we are running short of time, we will move to the next session. Over to you, Dr. Jitin. Thank you.
Thank you all. So the next session, we have for chairing the session, I invite Dr. Jalaluddin, the organizing chairperson. So you can introduce the speakers and the topic.
Dr. Jalaluddin, mute.
Okay. I'm audible? Hello?
Yes, sir. Yes.
Next talk is thalassemia, principles of management. I think it is a very, very relevant topic, especially in the COVID era, because peripheral pediatricians are getting a lot of transfusion cases because they are scared to go to the MCC or RCC like that. So we are getting a lot of transfusion cases, particularly for thalassemia. So it is relevant in today's topic. And the principles of management, when we have PG, same, we are giving transfusion. Now we are switch over to the components, packed RBCs, and Kelfer and Desferrioxam we are talking 25 years ago. But I think newer things came mainly of marital counsel, premarital counseling, and genetic diagnosis to prevent the thalassemia, mainly the severe thalassemia. So we have to focus on the counseling session, and we have new stem cell transplantation and bone marrow transplantation is coming in a big way. So I think cure is possible. Even without cure, now with good transfusion therapy, the age is reaching to 60s now. We are almost equaling the developed world. So we are having for this discussion today, Dr. Neeta Radhakrishnan. She is working as an associate professor at super specialty hospital. It's a pediatric super specialty hospital and a PG teaching institute. It is situated at Noida, Delhi NCR, under the state of Uttar Pradesh, Autonomous Institute under the state of Uttar Pradesh. I think we have selected from that region. I think Jitin has done a wonderful job because thalassemia is more in northern India comparing the south. Still, we are getting a lot of cases. I think that our madam is getting a lot of cases. So she is an apt person to this talk. Over to you, madam.
Thank you, sir. Thank you for the kind introduction. And thank you to IAP Kerala. Thank you to Dr. Jitin for this invitation. The slides is visible, right?
Yes, ma'am. Yes, ma'am. Got it.
So discussing thalassemia in 20 minutes is going to be a challenge. It will be a very abridged version, but I think we'll focus on certain aspects, especially what the chairperson has just mentioned. So thalassemia, we'll discuss why we are doing certain things rather than the nitty-gritties of what is done. I'll focus more on transfusion therapy, like Sir just mentioned. And we'll also see the pathogenesis, which will help us understand why these things are done. So now, conventionally, we've all been taught that thalassemia treatment is essentially blood transfusion and chelation therapy. But since then, a lot of things have changed. And now the focus is more and more on cure. And there will be, for cure, there are two options now, bone marrow transplantation. And then the FDA-approved treatments in the West or gene therapy. And then there are some agents which have come up, some new drugs which have come, which have reduced which can potentially reduce the transfusion requirement as well. So we'll see a bit of each of these. So before we get into the treatment per se, we need to know why we are doing these things. So thalassemia, as you know, is the most common monogenic disorder. And here, because of mutations either in chromosome 11 or 16, which is beta and alpha thal respectively, that particular globin chain production does not happen. The other globin chain gets produced normally, and because of that, in beta thal there will be excessive alpha chains, and in alpha thal there will be excessive beta chains. And these excessive chains precipitate inside the cell, inside a normoblast. And then it results in cell destruction. So the destruction of the cell can be inside the bone marrow, which is intramedullary. And for postgraduates in the group, this is why we do not get reticulocytosis to the extent that we see in conditions where destruction is occurring in the spleen. Like a spherocytosis, the degree of reticulocytosis would be much more compared to thalassemia for the same hemoglobin levels, because most of the destruction is happening inside the marrow itself. And this is otherwise called ineffective erythropoiesis. And a bit of destruction happens outside as well. So because of the destruction inside, there would be anemia, and the bone marrow tries to produce more and more red cells, and that's why there is expansion of medullary cavities. And destruction outside would cause organomegaly also, and there would be extramedullary masses also. And these used to be the earlier pictures of thalassemia children. I do see children coming like this even now, but in most centers where treatment is available and children are taken on a transfusion program early, this should be preventable. This kind of thalassemic facies should be preventable. Children should look like how they are supposed to look, like their parents. And like Sir just mentioned, thalassemia, the prevalence in northern part of India is much more than what we see in South. But still, because of migration, I'm sure there are a lot of patients who are coming from this area, this east of India to Kerala for working. So we also get to see a lot of patients from Bengal, who come. So we do see alpha thal and E-beta, thalassemia as well in our population, although beta thalassemia is more prevalent in this group, in this geographic region. So what happens because of all this destruction, there is chronic hypoxia. And because of chronic hypoxia, the bone marrow tries to produce more and more cell. And that is why there is bony deformities. There is increased GI absorption because the body does not know why the hemoglobin is coming down. And that because there is hypoxia, the gut tries to absorb more and more iron. And that also contributes to the iron overload in these children. And there is extramedullary masses. So around 10 years back, there was a change in the terminology of thalassemia. That what we used to call as thalassemia major is now currently referred to as transfusion dependent thalassemia. These are children in whom if we do not transfuse, they won't be able to maintain hemoglobin more than 7. And these children die if we don't transfuse them. They die in the first 3 to 4 years of life. And in this group, the genotype would be your beta thal major, your beta 0 or beta 0 beta plus, that group of patients. patients. It also includes some severe E beta thalassemias and even those patients who have severe alpha thal as well. The whole group of patients whom we used to call as thalassemia intermedia are now renominated as non-transfusion dependent thalassemia. Here, they will survive. They will live even if we don't transfuse. Their hemoglobin will be maintained around 7, but they are not essentially very milder. It's not a milder disease as such, because with passage of time, their morbidity increases. They have a lot of other complications that come in. So to highlight those aspects, these group of children are now are termed non-transfusion thalassemia, and then there are separate guidelines for their management as such. And in genotype, you have a milder version of beta. You're probably beta plus in this group, a milder version of E beta thalassemia coming here, and some of the other alpha thals who come in this group. And thalassemia minor, of course, where nothing really needs to be done by us. So other than what I mentioned earlier, that there is anemia and you are transfusing iron, and because of that, transfusing blood, because of that, there is iron overload. Hypocoagulability also is coming up, especially in those non-transfusion dependent thalassemia group of patients. And although thalassemia, transfusion dependent thalassemia, there is a fast rate of iron overloading. We need to be very aware of it from early on, so that all these organ damage can be prevented to a great extent by adequate use of chelation. In non-transfusion dependent thalassemia, it's a slow rate of iron overload, but this can be damaging. And this can also, other than your usual iron overload side effects, there could be patients who are coming in with pulmonary hypertension. There can be problems like leg ulcers, venous thrombosis also coming. So a whole new group of side effects or complications have been described in this group of patients. So now we will come to the first part of the discussion, that's transfusion therapy. So if without transfusion, your beta thal majors are going to die by 3 to 4 years of age. Now NTDT, although they can survive, that will be at a cost of morbidity and very poor quality of life. So hence that is also not allowed nowadays. Our transfusion goals are basically to relieve anemia so that your chronic hypoxia in the tissue hypoxia is prevented, because of which marrow stops having a hyperplasia. So because of reduction in marrow hyperplasia, bony changes reverse, splenomegaly, hypersplenism, etc. reverses. These complications come down with a good transfusion regimen. The child becomes more active, physical activity is ensured, school going is more smooth, adherence to school is more better. And of course, because of amelioration of hypoxia, your GI iron absorption also comes down. So we've been taught that we should give hemoglobin. We should first transfuse these children if our hemoglobin is less than 7. From the recent guidelines, not just the recent, even the previous edition also said that you would transfuse them when you document hemoglobin less than 7 on 2 different occasions. Why is that? Because even non-transfusion dependent thalassemia can actually come with a hemoglobin of less than 7 if you have a fever or some other cause. During a rapid growth spurt, etc., you can have hemoglobin less than 7. But if you're initiating transfusion, the second transfusion, you should wait for another hemoglobin fall to less than 7. So at pediatricians who are initiating transfusions for children with thalassemia, even though everything is classical, even if your HbF is say 95% and you are sure that this could be homozygous thalassemia, you really don't know whether it is thal major or non-transfusion dependent. So for that, you need to wait for two times. You have to demonstrate that HB is falling to less than 7 and then put them on a transfusion regimen. In those non-transfusion dependent thalassemia, even if hemoglobin is more than 7 and the child is able to maintain hemoglobin between 7 to 8, say, if there are facial changes coming up like in the earlier picture, if children are not growing well, if there is massive organomegaly, if children are having bony morbidity, fractures, etc., and in these conditions also we would put them on a transfusion regimen. So that is something new that has come up. And here, what would be your pre-transfusion? So earlier there used to be these regimens of pre-transfusion hemoglobin, where there used to be moderate transfusion regimen, hyper and super transfusion, all different terminologies which used to be there. Nowadays, what we follow is this moderate transfusion regimen, where hemoglobin pre-transfusion is kept between 9 to 10.5 gram per deciliter. We would want a higher trigger in patients who have having cardiac failure, but other than that, for most of our patients, it would be between 9 to 10.5. If children are maintained, so sir mentioned about COVID. So during COVID, we have seen children who did not have access to transfusion. So if hemoglobin is maintained lesser than that, say 7 to 8, for example, they would start seeing them. It becomes very obvious in their clinical presentation. They would have splenomegaly, extramedullary masses, etc. And how did this magical number of 9 to 10 come up? This came up very early in 1990s, where there were 2 centers in Italy where they were transfusing at a different cutoff. So they wanted to check whether for that cutoff that they selected, whether there was any difference in the bone marrow activity. So if they saw that if you maintain hemoglobin between 10 to 11, your erythroid activity in the marrow is just about normal, about 1 to 2. And if you maintain the pre-transfusion hemoglobin between 9 to 10, the erythroid activity actually is going up till around 2 to 4 times the normal. But if you maintain it less than that, it becomes much more. And this much more is actually problematic. So that is why this regimen is also called a moderate transfusion regimen, because there you are allowing some bit of erythroid activity to go on, but not much. And that is how this transfusion regimen got accepted. So we would keep it around above 9.5. And how do you adjust your transfusion schedule? So there are 2 ways again of adjusting. So if a child is coming to you, so many centers have seen patients come from centers who have been transfusing. So after transfusion, then they ask patients again to check hemoglobin after 1 week, 2 weeks, and then they wait for the hemoglobin to come to 9 and then come to the center for transfusion. You could do it that way also, or you could adjust it based on the presenting hemoglobin itself. So if you have a patient who has come with say 9.5 to 10, this is what you actually want. Your volume of transfusion would be 15 ml per kilo, and schedule it at the same interval in which the patient has come. So the patient has come to you after a 3-week interval, you will call the patient again after the next 3 weeks. So you want the same policy to follow. This is why is this happening is because most of our blood banks are packing blood to around 60%. So if you are transfusing 15 ml per kilo of this 60% packed blood, you are raising your hemoglobin by 3 gram percentage. So in this case, in the earlier case, if you are transfusing at say 10 gram percentage, you're giving a 13 ml per kilo, 15 ml per kilo, you would raise it by 3 gram percentage. So from 10, it is going to 13. And then again, in rate of fall in thalassemia is around 1 gram per week. So it will take another 3 weeks to fall back. So that is the calculation in which how you decide when to call the patient next, even without any testing for post-transfusion hemoglobin at all. If your patient has come with a lesser hemoglobin, you can increase the volume. If it is very less, you would probably increase the volume and schedule it earlier. And if the child has come more than 10.5, you can actually skip the transfusion at that time, or you can transfuse a smaller volume and call the patient 1 week later. So these are acceptable ways of scheduling transfusion in these children who are on a regular regimen. And this is also important to know, because many children would be registered to 2-3 blood banks. So most different blood banks would be giving you different packing. So that is also important to know. When a family comes and tells you that we were transfusing earlier at 4 weeks interval, and now suddenly we are supposed to give it like 2 weeks interval, the first thing you check really is whether we are actually transfusing them adequately, whether the blood bank is giving you correct packing and we are giving the correct volume of blood also. And it's always not based on hemoglobin alone. It would be a lot of other things as well. So traditionally, although thalassemia intermedia or non-transfusion NTDT used to be considered a milder form, it is actually not, because you don't transfuse, if you don't transfuse, they get to all complications of chronic hypoxia. So if they are developing features of chronic hypoxia, it is better to put them on a transfusion. In these patients also, better to put them on a transfusion regimen. And in these non-transfusion dependent thalassemia, two things are important. One, the first transfusion that you're going to give, be very, very careful. Give it only if it is indicated. And that is because when you transfuse them later, so non-transfusion dependent thalassemia kids are going to come to us little later in life. So they're going to come, say, at 5 years or 6 years, somebody picks them up for a splenomegaly with mild anemia, and that is how they get diagnosed. So when you transfuse at that age group, if you're receiving your first transfusion at that age group, your alloimmunization rate is around 50%. So alloimmunization is a horrible complication to deal in thalassemia, and because of which, if you see whether it is necessary, if your hemoglobin is maintained at 7 to 8 and the child is growing well, you may avoid transfusion at that point also. And second, many children with non-transfusion dependent thalassemia especially would respond to a trial of hydroxyurea. So you can even start a trial of hydroxyurea and see whether their hemoglobin is maintained above 8 and they're growing well, in which case transfusion may not be required in this case. But if they are requiring transfusion and they're having all these features like growth is retarded, development not attending school properly, or the child is dull, facial changes are there, splenomegaly is massive, then these children also would require a regular regimen like your transfusion dependent thalassemia. And this came up as part of this mega study called Optimal Care, which was published in 2019, that if children is non-transfusion dependent, when you give them intermittent transfusions, your chances of thromboembolic events, etc., are higher. But if you put them on a regular regimen, this might be lesser. So this is something new which has happened in the last couple of years. And even when you give them regular transfusion in E-beta-like scenario, where it is essentially non-transfusion dependent, your growth and development would be much better. So this also has changed, and subsequently there are new terminologies which are, so after a decade of TDT and NTDT, now you have more terminologies that are coming up, where even non-transfusion dependent thalassemias, if we may put them into a regular transfusion regimen, they may be termed as neo-transfusion dependent thalassemias. When you are transfusing, it is usually packed red cells. Whole blood transfusion is not given at all nowadays. It should be matched for the red cell antigens. So the more important, other than ABO and RH, you would be at least matching for KEL, because KEL is very common in our population. KEL mismatch is common in our population. And transfusion regimen is usually initiated at 3 to 4 weeks. Like I said, we calculate based on the pre-transfusion hemoglobin. Hepatitis A and B vaccinations have to be initiated. A also is given because A also, even if it is not transmitted through blood, even A causes liver damage. So that has to be prevented. So it's an easy thing that can be given. No need for any pre-medication to be given. No need for any furosemide in regular transfusions. And usually when you are using a leukodepletion filter, it is usually one filter bag per blood set that we usually use. And in severe anemia, children who are going to come to us with hemoglobin less than 5, they may be having an element of cardiac decompensation, in which give smaller aliquots, and in which case you need to give furosemide and may give 1 or 2 transfusions in 1 to 2 days, so that to build up their hemoglobins. And in children who come to us with a hypersplenism, and that also is a condition where you need to increase your pre-transfusion hemoglobin so that the spleen regresses completely. This is the usual transfusion monitoring chart that we follow. Other than when the child presents to us, the weight of the child, what is the pre-transfusion hemoglobin, what is the duration from the last transfusion, what is the volume that we are giving. So if we are using a leukodepletion filter, the filter would take up around 40 to 50 ml of blood. So that should be reduced from the bag volume that we are transfusing to know exactly how much PRBC we are giving the child. Leukodepletion, whether we are offering or not. So most blood banks would now would give leukodepleted blood. If that is not available, then bedside filters are available, which are usually available through the government. In most centers, it is available free of cost. If not, most societies which cater to thalasssemic patients also give leukodepletion filters at a nominal rate. So that has to be ensured to reduce the risk of alloimmunization. And then if you are documenting any transfusion reactions, which that also has to be recorded at every visit. And if it's a well transfused child, we can hardly make out from the face of the child. Child will be growing properly, spleen size, there will not be any splenomegaly, child will be active, there will be good appetite, and even child would do well in school. If there is a sudden increase in transfusion, suppose a child has been on a 3-weekly regimen and now they are coming at 1 weekly, in 1 week itself the hemoglobin has started to drop. First you think of whether the transfusion has been adequate based on the weight of the child. Maybe the child is growing, and because of that, your volume of blood requirement has gone up. That could be looked for. Maybe at times blood bank would give you lesser volume. So if depends on their donor also. If there is a adult, a male donor, maybe with a hemoglobin of say 14, 15, they will have larger collections. If it's a person whom they're collecting is around 12 gram hemoglobin, their bag would be less. So all these changes keep happening. So you need to check all that, and the hematocrit as well. If any of these are encountered, definitely if that has to be corrected. If your transfusion is adequate, but still the child is having an increase in transfusion frequency, then that conditions which cause that should be looked into. So this could be infections, this could be autoimmune or alloimmune sensitization, this could be because of folic acid deficiency. Surprisingly, in the geographical area where I work, I still see patients who have not been put on folic acid at all. So that can be easily corrected. Hypersplenism can increase transfusion frequency. And if these commonly corrected things are not there, then definitely evaluation for infections as well as bone marrow failure, etc., has to be looked into, and that has to be corrected. Now coming to the second part, which is chelation therapy. So like I said in the beginning, it is transfusional iron as well as intestinal absorption. Both this iron is getting into your body. Like when we take iron, oral iron, our iron is traveling along with transferrin, and it is stored as ferritin after our body's needs are over. But here, because the iron overload is so much, this transferrin becomes saturated, and there would be an element of free iron in the circulation. And this free iron is extremely toxic. And that's called labile iron or non-transferrin bound iron. And this non-transferrin bound iron is the reason for all the damage to the organs, which occurs as a result of chronic iron overload in patients with who are transfusion dependent, like thalassemia. So there are two ways, and in our body, there is no physiological mechanism to excrete iron at all. And because of which, whatever iron gets into the system, it will remain in the system unless we chelate it. And that is why chelation has to balance the amount of iron overloading and the excretion as well. So when you receive a blood unit, one PRBC unit would contain around 200 milligrams of iron. And so these children who receive around 100 to 200 ml per kg of PRBC in a year would again receive around 100 to 200 milligrams of iron per kg per year. So this is the amount of iron overloading that is seen, which comes to around 0.3 to 0.6 milligram per kg per day. And in addition, dietary, normal gut absorption would also be enhanced, especially in NTDT. And that again adds on to around 1 to 2 grams of iron per year. So these two are the sources. Iron being highly reactive, it causes reactive oxygen species generation, which causes lipid damage and cell death. And cell death is especially important in three groups of organs. One is liver, one is heart, and the third is endocrine organ. The liver damage starts early, around 2 years of age. That is why chelation has to start before that. And heart damage starts around 10 years of age. It's a progressive iron accumulation. We need to be aware of this fact, and we need to act before it starts attacking the heart. And endocrine organs also start getting affected around 10 years of age. How do we monitor iron? We monitor iron either by serum ferritin or by liver iron concentration. Now, serum ferritin is what we usually follow. It's very, very easily. But then when we are working in peripheral setup, most of the different labs will have different kits for monitoring ferritin. And because of which, if you are changing the lab, then one report will be 2000, another will come as 4000. So essentially, you should ask if you are not doing it at your own center, you should ask the family to stick to one laboratory and base the reports constantly on that. So we're going to monitor ferritin 3 monthly. So it's better to stick to one good laboratory which is doing it. And ferritin is an acute phase reactant. All of us know that. Any fever, any inflammation, especially hepatitis, will cause sudden increase in ferritin. And so one odd value does not mean anything. So parents just need to be reassured that you will check again another month later, and then we'll take it up from there. If it is still coming high, then we'll definitely go up on the dose of chelation. And ferritin does not actually predict your body iron sources. So many a times ferritin might be normal, but your liver iron may be very high, especially this happens in non-transfusion dependent health. So we need to have better ways of monitoring iron overload other than ferritin. But since the other ways are very, very expensive, most of us still resort, and even most guidelines also still resort to ferritin only. liver iron concentration, the best way to do it is from a liver biopsy. You can take it out and then send it. It is calculated per dry gram weight, and up to 7 is normal. This would be normal. 1.8 is the usual value, but up to 7 can be tolerated. But above 7, if it is coming, then that is going to adversely affect the liver. So it's going to cause liver fibrosis, and liver fibrosis is very, very important in thalassemics. We'll see why that is happening. So this is how you do liver iron concentration, but it's an invasive procedure. You can't subject them to annual liver biopsies, which is painful, and there may be these children may have liver involved. The ones who actually have liver fibrosis will have coagulopathies also, so that it becomes a little difficult. So what we use is a non-invasive technique of liver concentrate liver as well as myocardial iron estimation called MRI, and there is a particular software which is used, which actually calculates the relaxation time, and that tells you the amount of iron inside the organ. So it is helpful mainly for cardiac as well as liver iron, and there are values which are there. In myocardial, the value of T2 star less than 20 milliseconds, it implies that the child is at a high risk of liver LV ejection fraction was going to be low. So this is your classical image where this is your cardiac muscle, and that this area is looking okay, the signal. So when the iron accumulates, it starts becoming darker. So this is not dark, and here the liver, you can see that is also not dark. But here you can see that the cardiac area, it's become very, very dark, but the liver is darker, but it's not much, and it's not correlating. See, the liver and the myocardial iron does not occur at the same time. The iron overloading can be differential in different patients. So because of that, we need to, this is a very good way of assessing both the organs simultaneously. Here even spleen is showing some uptake, and on the in the third picture you can see the liver is very, very black, whereas the myocardial iron is not so much. So these things keep happening. So just basing our value on serum ferritin alone will be fallacious. So at least once in a year, an MR assessment is mandatory, and that can be again done through many centers are offering it free MRI nowadays. Now, what do you do for chelation? Chelation, the only way, because we need to have this NTBI is the actual pathogenic problem. We need to take out NTBI, we need to chelate NTBI and remove it from the body either through the urine or the feces. And this is done by these chelating agents. An ideal chelator should work 24 hours, but we don't really have ideal chelators. So we work with what we have in our with us. So traditionally what we used to use is this drug called desferrioxamine, and then following that deferasirox and deferiprone. Deferiprone has been available for a long time, and deferasirox came up around 10 to 12 years back. This came into the market, and these have been, all three drugs are available in our country, and we could use either of these. But for ease of using, most of us would start with deferasirox and then go up based on the response. Now, couple of things we need to remember from this slide is that desferrioxamine is always given as a subcutaneous infusion. There is no role of giving desferrioxamine along with blood as a 1 hour infusion or a 3 hour infusion, because the minute it finishes, another half an hour later, its work will be over, because it works only for 20 to 30 minutes in our body. So it has to be a long infusion, at least 8 to 12 hours. We give subcutaneous pumps for that, and they are taught. Children are taught how to administer, parents are taught how to administer it. So it is usually every day in the evening, and it goes on till night, and they remove the pump after that. And the ways of calculating, that's a huge different talk in itself, more practical aspects of this. Deferasirox, long half-life, we can give it once a day, and deferiprone, again short half-life, it is given usually 3 times in a day. What we need to be worried about is the side effects. Deferasirox, at the doses that we usually use, not many side effects. It's usually well tolerated. Couple of gastrointestinal upset, etc. may be seen. Deferiprone or Kelfer, that is the brand which is available in our country, it can cause agranulocytosis and neutropenia in 1% of the population. So 1% means 1 in 100 is a very high number. So we need to be monitoring CBCs along with this. And desferrioxamine, when you give it at high doses and over a long period, there is a huge protocol that comes into monitoring these children, both for growth as well as for ocular or auditory toxicities especially. And so most centers which would do it would have all this in place. And then something which came up after this is that you could start combining drugs together. So if you combine drugs together, you can achieve something like a synergy. And that synergy is through this mechanism called shuttle effect. So there is deferriprone would remove it into the intracellular, from the cell, it would remove it into the extracellular compartment. And whatever is there can be chelated further by desferrioxamine. So these kind of protocols are very widely used now for your children who are on chelation. When do you start chelation? For a new thalassemia major child, we'll wait for the first 10 transfusions or for serum ferritin to go up more than 1000 nanogram per ml. In NTDT also, you would chelate. So in NTDT also, who is receiving only say 1 to 2 transfusions in a year, still these children may require chelation because, like I said, gastrointestinal iron overloading is high. So here serum ferritin, you use a smaller cutoff of 800. And agents to use, I already mentioned. And high risk or emergency chelation is when you need to do a BMT or when the child is in cardiac failure. You want ferritins and your iron overload to come down drastically and quickly. And in those conditions, we generally use IV chelations, as a continuous IV infusion can also be tried. When do you use combination? When you don't have adherence, when you don't have good results to monotherapy, either due to adverse effects or due to ferritin not improving. So in these conditions, an additional drug is used. So currently, desferrioxamine with deferriprone, desferrioxamine with deferasirox, or both oral chelators together also have been used. And all three chelating agents also have been used, but mostly in study research protocols where a lot of monitoring also has to be done. And this is how you monitor a chelation child with, again, 3 monthly. You would look at ferritin, you would look at the dose of the child. And if it is deferasirox, you would need to monitor for proteinuria, creatinine, SGPT, and any other adverse effects that are required. So complications of thalassemia, a lot of complications. This is the classical NEJM paper which came out many years ago, which showed everything, all the complications possible. And this is still seen in many families. A lot of things have to be looked into. So these are complications, essentially are 3. Complication is because of the disease per se. Complication is because of hypoxia, causing a lot of complications. And third, complications would be because of chelation and the drug which is used for chelation. So that also has complications. So that would result in growth defects, pubertal defects, cardiac complications. And so then again, there is a monitoring protocol again for that. In children who are less than 10 years is essentially CBC, ferritin, along with some liver function and annual monitoring for transfusion transmitted infections. But in children more than 10 years, a lot of other things come in: cardiac evaluation, endocrine evaluation, bone densitometry, etc. are also added. So again, Thalassemia International Federation has a whole protocol. Even in India, there are guidelines which have been published, so this is what we are following: an annual monitoring which kind of looks at everything possible in one go, so that we document it and keep it in the file, and so it is not missed. And like in cancer care, there would be a role of multidisciplinary teams. So you need a cardiologist, you need an endocrinologist, you need gastroenterologist with hepatology follow-up also is required in these children. So even if you don't have all this under one roof, you still need a team to be followed. At least a virtual team should be there so that the child is seen at least once a year till the time, even if the child is being taken up for transplant, still we need to do this. And even after transplant, of course, there would be a team that would follow. Since the next talk is going to be on BMT, I'll be very brief here. Currently, the only curative option available for in our country is bone marrow transplant. And Lucarelli classification was a classification which told you whether these children would improve with transplant. So if a child is on regular chelation, a child has a hepatomegaly, which is more than 2 centimeters, and if child has liver fibrosis, these are things we take in. And if none of these things are there, if there is child is on very regular chelation with no hepatomegaly and no liver fibrosis, then the overall survival after transplant would be 95%, and thalassemia free survival would be 90%. Whereas if child had any of this, it would come down. And if the child has all of this, as in poor chelation, hepatomegaly, and liver fibrosis, then the thalassemia-free survival would be coming down to up to 65%. Now, this is why, as periphery, I mean, as pediatricians who monitor these children, even if the child is going for transplant, many families will tell us, we are okay, we already got a donor, our date is 1 year later, we are just coming to show you. So that should not be the way. It has to be a very strict follow-up till the time the child goes to transplant, and to ensure that there is no liver fibrosis, to ensure that ferritin is maintained well, and to ensure that there is no hepatomegaly, so that the child, when the optimal outcome of the transplant can be achieved. And subsequently, from CMC, another classification came up based on the age and the liver size. So the ideal age currently recommended is children should be transplanted less than 7 years. So, and then again, finances are no longer a barrier, because Government of India is supporting BMTs for thalassemia children. So if you have a child with thalassemia, always send to a transplant center which is being supported at least, or which is able to fund raise funds for patients, so that this option can be given to every child. Because after the age of 7 years, after 7 to 10 years, it becomes difficult, its procedure becomes difficult, and then most families would back out at that point of time. So every child, at the time of diagnosis, as pediatricians, they should be counseled for BMT, because they have the trust they have with the primary care pediatrician is immense. So if the pediatrician tells them that they should go and get an option for transplant, they would mostly listen to that. So that has to be given. And nowadays, if you don't have a sibling donor also, unrelated donors can be taken up. And there are refinements in haploidentical transplant now. So that would also become the norm very soon. And finally, few new things which have come up is that in beta thalassemia, there is any condition where there is increase in hemoglobin F, the disease would become milder. So if we increase hemoglobin F by any mechanism, like by increasing hydroxyurea, by giving hydroxyurea or few other agents, these children may have a milder phenotype. Their transfusion frequency would come down. And in this context, there have new drugs which have come out recently, which have shown that transfusion burden has come down, as reduces by 33%, and in a good 10-15% of these patients, transfusion independence were also seen while the child was on this drug. And similarly, new treatment options that have come out are gene therapy. So it could be either correcting the gene per se. So this is nothing short of a transplant, but here you don't want a donor. You're taking the child's own stem cells out and correcting it outside. The gene is corrected, and with the vector, it is given back into the body. And once in the body, it goes in and sets itself up. And this is the drug which is FDA approved, the gene therapy procedure which is FDA approved. Now it is currently approved in the EU, and the recent data which was published in the recent ASH of 2020, they have transfusion independence in 90% of their phase 3 subjects. So that is a very good data to bank upon, and this is soon going to change the way we are going to treat these children. And because we are not transfusing them, even if they had very high liver iron concentrations to start off with, on follow-up, all the gene therapy subjects, their actually iron overload also starts coming down with time. So this is like a transplant, it's like an autologous transplant. You're taking out the stem cells of the patient and then reinfusing it back after giving chemotherapy. So that needs a good center which has all the backup for doing a BMT per se. And finally, even without gene correction per se, even if you edit the gene and you just remove the BCL11, that also could be helpful. So this also came in January of this year, January 2021, that even gene editing strategies are going to be workable. So cure is just out there. We just need to wait and most of our patients are going to be benefited in the next few decades. And like sir mentioned before we started, even though cure is there, even though treatment, chelation, everything is given by the government, it is still always better to prevent. So when we are dealing with these families, definitely counsel them for prenatal, at least for the next pregnancy. And in areas where thalassemia is very prevalent, mandatory screening of all antenatal women should be done. There are very regular protocols available, and antenatal diagnosis of hemoglobinopathies is currently a very strong focus for the government also. So you can just follow either with a red cell indices followed by HbA2. That should be good enough for evaluation. And if both parents have found to have a high HbA2, then go in for prenatal diagnosis. Either if you in the first trimester, it is usually a CVS, and if they have missed the boat, if they are coming in the second trimester, even then it is possible by globin chain analysis. So I would like to conclude by saying that these are times which are very good for both benign as well as malignant diseases in our specialty. And in thalassemia, always the emphasis should be on prevention. If we have not prevented and a child is born in India, every year 10 to 12,000 thalassemics are being born. So if we have a child, a new child, opt for cure. And if that is also not, even if BMT is an option, regular chelation and transfusion should be followed. And if BMT is not an option, even then with regular chelation and transfusion, they can achieve a very good quality of life. And these are good documents which have come from Thalassemia International Federation. This is from my center. Thank you.
Thank you, madam, for an excellent presentation. There is 2 questions in a chat box. Just we will finish it off and move on to the next session, which is the government scheme which supports transplant in thalassemia kids. Another question by same Dr. Vinita. Please suggest reference guidelines for combining chelators in kids with cardiac and liver iron overload, despite adequate dosing of Desferriox.
Okay, I'll be quick. So National Health Mission is supporting thalassemia treatment in our country. So the blood cell of National Health Mission, and they have a Coal India project. Dr. Revati would be talking about it, I think. So Coal India project is a CSR activity of Coal India, where they are supporting up to 10 lakhs per transplant in select centers in the country, where they can avail free transplant. And reference guideline for combining chelators, it's been published in IP, and I think even there has been guidelines which have come out from the PHO chapter also on chelation therapy. I'll be happy to share. Thank you.
Thank you, madam, for an excellent presentation. We will move on to the next topic because everybody's RBS is going down. So we are having the last talk, which is pediatric stem cell transplant, when and how. The talk will be given by Dr. Revati Raj. She is a consultant pediatric hemato-oncologist and specialized in transplantation. She is now working at Apollo Hospital, Chennai. She had undergraduation from Madras Medical College, Chennai, and DCH from Chennai Child Institute and MCC. And she had MRCP Pediatrics from UK and FRCP in Hematology, UK. So over to madam.
Thank you so much for the kind introduction and for the invitation. Are you all able to hear me and see my slides, please?
Yes, ma'am.
Okay. So as you said, everyone's sugars are running low. So I try and stick to my as much as possible minimum time so that people can get to their lunch. So we are talking about blood and marrow transplantation, and I just cannot start without giving you an introduction to what are stem cells, because everyone asks each other, do you know about stem cell therapy and what are stem cells? So cells that are completely capable of differentiating and self-renewal are called stem cells. The main stem cell we have in our body, which is totipotential, capable of giving rise to all cells in our body, is our embryonic stem cell. And that is coming from the fusion of the egg and sperm and can give rise to all cells of the body. Then each part of our body has committed stem cells, and these are called pluripotential. They can give rise to every cell of that particular organ. So these are embryonic stem cells, and they can produce any type of cells in our body. You can put them on a culture plate, they'll produce pancreatic cells. And as I said, each part of our body has stem cells that can give rise to different cells of that particular organ. So cardiac stem cell, neural stem cell, and hematopoietic stem cell. We have a new type of stem cell, which is now called induced pluripotential stem cell. So they can take your skin fibroblasts, change their genetic makeup in such a way that they have a capability of self-renewal. So this is magic in the lab, and people are using this for testing drugs and making cell lines of one particular organ and things like that. So this is for the future, and we can use them for curing incurable diseases as well. So embryonic stem cells, the adult stem cell, and induced pluripotential stem cell. I just want to add here, a lot of people think cord blood is embryonic stem cell. It is not. It is just the baby's blood stem cell, and the fetus makes excess amounts of hematopoietic stem cell, and that is in that 100 ml of cord blood. So it can only produce blood cells. It cannot help you cure neurological problems or cardiac problems, as the cord blood banks seem to advertise. So that is one take-home point that I want all of you to know, that cord blood does not contain embryonic stem cells. They are only pluripotential adult stem cells in the cord. So we are talking about hematopoietic stem cell transplantation. It used to be called BMT, bone marrow transplantation, but now we call it blood and marrow transplantation. These stem cells are sitting beautifully in a spongy marrow, and every day they are supported by all the chemicals in the bone marrow, erythropoietin, GCSF, thrombopoietin, and they grow to divide and produce red cells, white cells, and platelets. And they completely work 24/7. If they stop working, we get into trouble. Hematopoietic stem cell transplantation is taking these cells and transferring them. So it's as simple as that. If you put it back into your own body, then it's called autologous. If you take these stem cells and put it into another person's body, then it's called allogeneic. So you can see worldwide the number of transplants are increasing because the awareness is increasing. So we'll first talk about autologous transplant. Why would you use autologous transplant? If a child has a solid tumor like a neuroblastoma or Hodgkin's lymphoma, for which we have to give very high doses of chemotherapy, but the bone marrow will not be able to tolerate such high doses. So we take the blood stem cells, keep them in the freezer, and then give the child high doses of chemotherapy, and we use them as rescue. So this way we are able to deliver high doses of chemotherapy to a child. And as Neeta pointed out earlier, autologous stem cells are also going to be the future when we use gene therapy. So whatever missing genes we can add to the stem cells. What are the conditions for which we do allogeneic transplant? So this is the most important part. So when stem cells are themselves defective, that condition is called aplastic anemia. And transplant helps beautifully for children with aplastic anemia. In fact, a condition that had over 90% mortality, we now have 90% cure rates. Neeta had spoken about red cell disorders like thalassemia major and sickle cell. And sickle is a problem in Kerala, and a combination of sickle and beta thalassemia can be cured using transplantation. White cell disorders, primary immune deficiency disorders where they don't have functioning neutrophils or lymphocytes, or children with relapsed refractory leukemia can benefit from transplantation. If they have platelet function disorders by birth, like Glanzmann's thrombocythemia, they can also benefit from transplant. The monocytes in the blood go into the tissues and become macrophages, and storage disorders that affect monocyte macrophage system like mucopolysaccharidosis and adrenoleukodystrophy and Gaucher's can be eminently cured using transplantation. There are some disorders which affect the macrophages, and they affect osteoclasts, which help in bone resorption, like infantile osteopetrosis, and they can be cured using transplantation. Macrophage defects like in HLH. So these are the indications for which we are doing transplantation. We remember the 10 commandments whenever we have rules to life. So I'll go through the 10 steps of transplantation over the next 10 minutes. First, we need a patient. Then we need a donor. Then we need to connect the patient and the donor and prepare the patient to receive the new stem cells, give the new stem cells, and provide the supportive care until the new stem cells are taken up by the child. and then make sure that these stem cells are not rejected by the child, or the new stem cells don't reject the child, and provide adequate follow-up care. So these are the main 7 steps of transplantation. And if I take you through them sequentially, the most important, again, take-home message from this is that transplantation is not a surgical procedure. All other organ transplants are surgeons, kidney, liver, heart, lung. So we are physicians, and transplantation is a medical procedure. Only organ that you can donate, and it's self-replenishing. So you don't lose anything by the donation. Within a week or so, your body makes up all those cells back. So first step is patient selection. Neeta had already pointed out, this is a paper from 2011 that in thalassemia major, if the patients are transplanted less than 7, they have more than 90% chance of cure. But most of the patients, unfortunately, are referred after they move from pediatrics to adults, and after they are 12, after they are 18, and that's when the referrals are late because they are started with iron. So look at this. These children, the child on the left, he's 15 years old. He has a fully matched sibling, but you can see he's not grown at all. He's under transfused, post-splenectomy, heavily iron overloaded, and he's not a good candidate for transplant because the first step would be to give them chemotherapy, and they won't be even able to tolerate the chemotherapy. These are twins whom we one child had thalassemia major, the other one was the fully matched donor, and the outcome is very optimal now because he was transplanted when he was 2 years old. This is a child with severe combined immune deficiency who came to us at 6 months of age with such bad perianal ulcer, failure to thrive. She was only 3 kg. And this is her after a successful transplant going back home. So this is a child with Griscelli syndrome. So neurological manifestation. He had come with recurrent seizures with HLH. So this is also corrected using transplant. We're now moving into an era where molecular diagnosis is possible, and we're able to do transplants for rare disorders. So this is a condition called IL-10 receptor defect, where the baby had presented with inflammatory bowel disease as an infant. Very tough children. There is no way he could eat all his life. And he was at the age of 1.5 years, never had eaten anything and only on elemental formula, failure to thrive. And he was cured using a transplantation. Hurler syndrome. So you can see this girl had a transplant 3 years ago for Hurler, and we've documented normal enzyme levels after a successful transplant. So this is all conditions which we have to choose the patients carefully. Next, we need a donor who's going to donate stem cells for them. And this is very important because the ideal donor will help make sure that the cells get into the body, which is called engraftment, and they don't get rejected by the patient or by the donor, which is called graft versus host disease or graft rejection. So HLA typing is the basis to transplant. So HLA stands for human leukocyte antigen. And this is a mechanism by which we say, this is me, this is you. If it's me, I will accept. This is you, I won't accept. So the chance that we will have 100% match HLA donor within a family is only 30%. So the rest of the 70% of the patients don't have a matched family donor. So this is one of the children that had come with SCID and ALL, and we transplanted her at 1.5 years age, and this is her at her 5th birthday, growing beautifully. So some of the children who don't have a fully matched donor, this is a technique that is now coming up, and people may ask you about this, called pre-implantation genetic diagnosis. So they have embryo selection. So this is a child with Thal major who went abroad to have an embryo selection, and to have a Thal negative HLA matched baby brother who donated the stem cells and who's now transplanted and doing well. So this is one group who have a fully matched donor. Then what about the rest? They don't have a matched donor. What can we do for them? Worldwide, there are about 30 million donors who are registered to say that they are ready to donate stem cells. So these are stem cell donors who've just done their HLA typing through a buccal swab test. And their data is there on a computer database, which all of us can enter our patient's HLA we can find a match in Germany, in Canada, or any part of India. And Datri is the Indian stem cell registry. All of you can register. In fact, I'm proud to say here that Kerala database is the biggest in the country. So most of our patients get unrelated donors from Kerala. And matched unrelated donor transplants are now improving the advances. So we've had children with Wiskott-Ulrich syndrome, with thalassemia, so many transplanted through matched unrelated donor. So here we can do another 30% of the children. What about the rest 40%? They don't have a family match, they don't have an unrelated donor. How can we help them with a transplant? So this is a technology which is called haploidentical transplantation, which is new. So the donor is only half match. What can we do? We can put the stem cells through this machine and it will clean out all of the lymphocytes. So that's called CD34 or stem cell selection technique. And this has helped us save many lives. The problem is the stem cell selection technique itself cost about 12 lakhs. So in addition to the transplant cost, we're adding a burden for the family. So this is one of the latest technologies in half match. And in our mind, usually latest means it's going to be more expensive. But haploidentical transplantation, half match using cyclophosphamide is the main revolution we have seen in our lifetime in transplantation. So if the half match stem cells are given to the child, the T lymphocytes from the donor enter the child's body and they start dividing madly. And by 72 hours, they have realized every cell in the child's body is different. So these are called alloreactive T lymphocytes because of the half match. And on day 3 and day 4, we can introduce cyclophosphamide. It poisons only these lymphocytes which recognize the child as being foreign, and they spare the stem cells. So this half match stem cells, haplo-PTC-Y. Now every child has a donor, so we are able to transplant as well as the match sibling donor. So we can have donors from the family, we can have donor from unrelated registry, or we can have a half match family donor. So we have a patient, we have a donor, then we have to prepare the child to receive new stem cells. So this is the main meat of our transplant. We use high doses of chemotherapy. What we use today is going to have an impact on the child today and for the future. So the child has to be ready to receive very, very high doses of chemotherapy. Each condition, we use different type of chemotherapy. For example, if they already have aplastic anemia, stem cells are 0. So you don't need to give high doses. But if they have thalassemia major, we need to remove all their stem cells. So we need high doses of chemotherapy. We have advances here also. We have newer drugs like triosulfan. Busulfan was very hepatotoxic. Veno-occlusive disease rates were high. Hepatotoxicity was high. Gonadotoxicity was high. We now have better drugs like triosulfan-based conditioning, where thalassemia-free survival is very high, and we're using it for a lot of the benign hematological conditions. So we've prepared the child for 7 days to receive the new stem cells, and then the stem cells we have to take from the donor. This we can take from peripheral blood, from bone marrow, or from cord blood. All 3 ways you work equally well. Cord blood has very, very few stem cells, as you can see in the cartoon to the right. Bone marrow harvest from the donor we take under general anesthesia, and we take 10 ml per kg of the recipient's body weight. Cord blood is collected during delivery, and peripheral blood stem cells is another method where we give 4 days of GCSF injection. Some of the stem cells come out into the blood circulation, and these are collected using a machine called the Cobe Spectra or the Optia machine, which is like a stem cell or a platelet pheresis machine. Once these stem cells are collected, the patient has to be looked after in a clean air room. So this is our transplant room. We have a HEPA filter area with 1:1 nursing. We have to look after a child who's received heavy doses of chemotherapy and has mucositis with a WBC count of 0. So supportive care is important. We have to work with infectious disease specialists, ID team to have the challenge of Klebsiella and multi-drug resistant bacteria. We need to train our nurses. We need to look after sick children who have WBC count of 0. After the new cells are taken up, they should not get rejected. They should not cause graft versus host disease. So the children remain on immunosuppression. Graft versus host disease is a big problem. It can affect the skin, it can affect the gut, it can affect the liver, and it's a scary condition to be in. And rejection is also scary because you started off with thalassemia and now you're back to thalassemia. So rejection is also a big problem. So we try and have mechanisms to avoid both GVHD and rejection. Once the child is discharged, we monitor them for infections, we watch them for their growth, puberty, fertility, vaccinate them. So this is an important part of follow-up. We need to do long-term follow-up because we've given them chemotherapy and high doses of radiotherapy sometimes. And the main thing is to have 24 hours access to a physician because the immune system is low and we may have problems with infections. This is where joint teamwork with the community pediatrician is important because the children might live in small villages with no access to antibiotics or tertiary care, and they may develop an infection there. So contact with primary physician is important. We need to follow them up for late effects, watch their puberty, fertility. And this is an important concept for physicians and the team as well. We have to learn how to deal with mortality. Not all children get cured. During the time when they have a WBC count of 0, there is sepsis-related mortality. Graft versus host disease can cause mortality, sometimes disease relapse or progression. So we have to learn to accept the 10 to 15% chance that we may lose that child. Quality is important. Always we have to monitor whether we are doing the right thing. This is our paper, transfusion children of thalassemia and transplanted, and there was such a big difference in quality of life, and the transplanted children scored better compared to the transfused children in all parameters of physical, emotional, social, and psychosocial. So it is important to offer early transplant for our patients. We should always be mindful of the cost of care. People are worried that transplant is expensive, this family cannot afford. But the long-term transfusion chelation costs also increase exponentially. And this is where we have to say that for this family, if they put in the trust and do the transplant early, we'll be avoiding lifelong commitment to a chronic disease. Transplant access has been an issue. This was earlier in 2008, but I'm now happy to say in 2021, there are over 100 centers in the country. We have training programs for young pediatricians who are interested in pediatric hem-onc and transplantation. So over 100 centers are there, and every part of Kerala also has their own transplant center, which is the best news. This is our transplant unit. We're coming close to 1,000 pediatric transplants, and the majority has been for thalassemia and for primary immune deficiency disorders. So the future is bright for our patients. Transplantation is going to be the basis for gene therapy. So whatever missing gene, we'll take the child's stem cells, incorporate the missing gene in the lab, and give it back to the child after giving chemotherapy. So it's like an autologous transplant. There is no problem with rejection or graft versus host disease. So hopefully this technology will come into our country as well. So I'll end with these take-home messages to say any hematological disorder, think transplant early. For example, if you see a child with osteopetrosis, they have to be transplanted before they go blind. If you see a child with Hurler, they have to be transplanted before their second birthday, before the growing brain gets damaged. Any volunteer donor for unrelated donor stem cells, please encourage them. If you have young family members 18 to 55, please encourage them to register as a donor. If your patients ask, should I store cord blood? It's no longer recommended if there's no family history of a blood disorder. And we need to work with government and non-governmental agencies and guide families to reach the path of cure. Because if the primary physician who's counseling them is not convinced that transplant can help, it's very difficult for them to reach a transplant center. I want to end by saying that every life is valuable and we can only give them a chance of cure if we work as a team. I'm very indebted to the group of physicians with whom I work, and all the nurses and the patient families who made all this work possible. Thank you for your time.
Thank you, madam, for a wonderful presentation. I think take-home message for practicing pediatricians, early referral if the family is willing to go for cure, and they are preferring transplant. Any questions, please?
Usual question will come, how much does transplant cost? And Anita had already said that the governments are sponsoring. On average, if there is a sibling, fully matched sibling in the family, we need about 12 to 15 lakhs for a sibling allograft. And if it is any of the alternate donor transplant, either unrelated or half match, we will need at least about 20 to 25 lakhs. So that is the amount that is required. And usually we try and have a mixture that some the family can provide and some the government will provide, some NGOs will provide. So there are avenues. What we shouldn't do is already decide they are poor fisherman family, they cannot afford. So let's not tell them about the transplant. So our job is to counsel. They have to decide whether they're going to take the steps to try and get all the money.
So Vinita is asking something.
You have to unmute, Dr. Vinita.
Unmute. Unmute and ask, Vinita.
Yes. No, I would thank you very much, madam, for the very nice talk. And I would like to use this opportunity to share the good news with everyone that Malabar Cancer Center, this is our center which we currently organize this meeting. And our center has started a stem cell donor registry.
Very nice.
On a government scale. And it's right now the beginning phase, but the aim is to reduce the cost for matched unrelated donor transplant.
Perfect.
Right now we are getting from Datri and DKMS, and in future, maybe after many years, when more and more Malayalis contribute to the pool, then we'll get more unrelated donors from the locality rather than from somewhere in the world.
Yeah, I am very happy you've done this. Kerala nurses changed medicine and how we serve patients, and then now other people have learned from Kerala nurses, and Kerala donors are the biggest Datri donors. So your leaders, and you're already talking about cancer prevention programs in the state. So really well done. Yeah.
Thank you, ma'am.
Thank you. So we will wind up the session, Jiten, and we will go for vote of thanks. Jiten?
Dr. Jitin?
So I think Jitin mentioned
There's some range issue there.
Range issues. So
Kumar can give the vote of thanks.
Okay, sir, am I audible?
Yes,
Yeah,
yes, yes.
audible.
Okay. So good afternoon, everyone. So this is the first subspecialty conference of IAP Kerala this year. And as a pediatric oncologist, I am very happy that hematology oncology chapter got this opportunity to conduct this conference in the online platform. Because of this COVID issues, we had actually limited this program to an online venue. And we had speakers from both international as well as national levels. And we had an excellent session on various aspects of hematology and oncology care in pediatric population. And basically all these topics were selected based on this practical aspects covering the different aspects of pediatric oncology and hematology. I hope the practicing pediatricians, for them it was actually beneficial, so that these topics can be incorporated. Whatever knowledge has been gained has been incorporated, can be incorporated in the day-to-day practice. And at this onset, let me first of all thank the organizing committee and organizing team of IAP Thalassery, which includes me also, for conducting this conference in a very nice way. Except for some glitches or in between the program, I hope this program had served the purpose for this conference. And next, let me thank all the faculty members who had actually taken their pains to attend this conference, even though if it is a hard half-day conference. They have spared their valuable time on a Sunday morning till afternoon to share their experience on the various topics that we had seen in this program. Let me thank on my behalf and on behalf of IAP Thalassery and IAP Kerala, a very big thanks to all the faculty and delegates of this program. Let me thank Johnny sir for allowing us to share the online platform of IAP Kerala to conduct this program. Our past president, Dr. Jalaluddin sir, our national president, Piyush Gupta sir, state president, TP Jayaraman sir, and state Thalassery branch president, Sakriya sir. Everybody has actually joined in time and contributed their aspects into this, conducting this CME in a very good way. I thank you one and all for attending this program. Jai IAP Thalassery. Thank you. Thank you all. Shall we wind up, sir?
Yeah, thank you. Thank you all.